Samreddy, am I audible?
Please start, sir. Please start.
You are audible. You are audible and visible.
Good afternoon, all delegates, chairpersons, and moderator and the speaker. We are starting the fourth session, pediatric session. And I would ask Dr. Shivaprasad Babu to take over from here.
Thank you. Thank you, Dr. Srikanth Garu, Secretary of IMA Tenali. Now I invite Dr. Chandrasekhar Reddy Timmapuram Garu as a speaker for the current session. Dr. Chandrasekhar Reddy Timmapuram Garu, son of Dr. Gopala Krishna Reddy Garu. He did MD Pediatrics from PGI Chandigarh, the prestigious institute. Did SSC in 83 from Sri Venkateswara Balakuti, intermediate in 83 to 85 from Kendriya Vidyalaya, Tirupati. MBBS from Guntur Medical College in 85 to 1992, and post-graduation from 93 to 96 at Chandigarh. Now he is the managing partner and head of pediatrics at Sri Ramachandra Children's and Dental Hospital. His professional experiences from 1996-97 to senior resident in PGI Chandigarh. Till date, he is doing private practice. He worked as a senior resident in PGI Chandigarh after completion of MD till 1997. Has several publications in national and international journals. In private practice at Sri Ramachandra Children's and Dental Hospital from 1997 onwards. Worked as a secretary for Indian Academy of Pediatrics Guntur branch from January 2015 to February 2017. First hospital in Guntur district to get DNB accreditation pediatrics from National Board of Examinations. Presently involved in practice and teaching at Sri Ramachandra Children's and Dental Hospital, a 100-bedded, well-equipped, fully equipped hospital. Qualified Improvement Advisor certified by Institute of Healthcare Improvement. Presently working as a secretary for Indian Academy of Pediatrics Guntur branch from January 19 till date. He published many research publications, candidemia in pediatric ICUs, oral itraconazole in treatment of candidemia. First person to introduce neonatal ICU in Guntur district. Adapted to villages in the district to serve the poor. Now I invite Dr. Chandrasekhar Reddy Garu to start the topic.
The chairs to comment, please, before we start. The chairs, please. Narasimha Garu and Chandrasekhar Garu. Before Dr. T.C. Reddy Garu starts, any comments?
No particular comments, but I think the topic which was selected today is very useful for all practicing pediatricians even, because nowadays the ICU concept has become that is in vogue in everywhere, starting from the district quarters to the even to the taluk headquarters. So everybody should know what is actually the respiratory failure and how to deal with it, apart from the other routine complications like septic shock and all those things. So I think any comments from Dr. Narasimha Rao Garu, or otherwise?
Unmute Jay. Narasimha Rao.
Dr. Narasimha Rao Garu, please unmute yourself.
Hello?
I think we can start, sir. Sir, Narasimha Rao Garu unnaru. Is unmuted, sir.
Maatladandi, Narasimha Rao.
Welcome, Chandrasekhar Reddy. And it is a vast subject. Make it precise and simple.
Okay. Thank you, sir. Thanks for the kind introduction. At the outset, I'd like to thank IMA Tenali, Dr. Samreddy Garu, Dr. Srikanth Garu, and my dear friend, Dr. Shivaprasad, for the kind invitation and giving us opportunity to really speak about a topic which is of use day in, day out. A very vast topic. I'll try to make it as simple as possible. And probably at the end of the talk, we will all be wiser. So, can I share the screen now?
Yeah.
Yes, clear, sir.
I also thank Dr. Chandrasekhar Garu and Dr. Narasimha Garu for the kind words. So, is my screen visible, sir?
Yeah, it's visible.
Yeah. So, respiratory failure is a very, 1 second, no, it's not, cursor is not. Yeah. Straight away, we'll go to a couple of emergency room scenarios which we see day in and day out. See, a 2-year-old child presenting with respiratory distress with a maintained saturation of 97% with normocardea. So what are we supposed to do? Definitely oxygen therapy by itself is not an answer. Say if the saturation is 90%, what are we supposed to do? Say if the saturation is 70%, what are we supposed to do? See, all these are normal carbon dioxide levels. A child with pathology of Fallot presents with breathing difficulty has a saturation of 70%. What are we supposed to do? Same pathology of Fallot child has a saturation of 50%. What are we supposed to do? The last scenario is a similar child with respiratory distress with hypoxia and hypercarbia. Obviously, the first case scenario is respiratory distress, and the later cases are respiratory, type 1 respiratory failures, and the last scenario is one of type 2 respiratory failure. So, I would like to answer all these questions at the end of the session. Before that, we will just look at the armamentarium we have to really help these needy children. Oxygen by nasal prongs, oxygen by mask, NRBM, venturi mask, and the latest addition to our weaponry is your humidified high flow, heated humidified high flow nasal cannula, CPAP, and ventilation. It can be conventional or high frequency. These are the weapons we have to deal with the emergency scenarios. So, what are the things one should really watch out? Flow rate, duration of oxygen therapy, FiO2 given, what is the peak, what is the stretch involved in the lungs. Stretch by me, what I mean is the peak inspiratory pressure. So only if we really take care of all the first 5 variables, then only we can prevent lung injury. So safe ventilation, safe oxygen practices, minimizing lung injury is the rule of the law. We have to really practice. How we go about, we'll discuss in due course. So what are we going to see today? Are the definitions, why children are more prone, respiratory distress versus respiratory failure, a brief discussion, what are ecological causes, types, signs and symptomatology. But I'll be stressing more on the management, oxygen therapy, what are the delivery systems that are in use, a brief discussion about non-invasive ventilation and non-protective invasive ventilation methods. So unlike adults, where cardiac arrest is usually because of a sudden cardiac event, children, they really give us some time in the form of having respiratory distress before they go into respiratory failure and cardiopulmonary failure, ultimately resulting in cardiac arrest. If it is circulatory cause, a short precipitating cardiopulmonary failure. Today's our topic of discussion would be the left side of the limb, which is respiratory distress and respiratory failure. So respiratory insufficiency can be because of lung failure or pump failure. Lung failure is always obviously type 1 respiratory failure. If untreated, will obviously land into type 2 failure. Pump failure is something related to the CNS and the mechanical defects of the airways, which can cause respiratory failure, type 2 respiratory failure. So we'll just go for some definitions. So what is acute respiratory failure? It's a common medical emergency defined as inability to provide oxygen and remove carbon dioxide at a rate which meets the metabolic demands of the body. Type 1 is defined as something PO2 of less than 60 or a saturation of less than 88 with or by an acute increase of PCO2 of 10 to 15. The catchword is if CO2 rises by 10 to 15, the pH should be somewhere around 7.32 or less. If CO2 is high and PCO2 stays static at 7.4, it falls.
ఆడియో ప్రాబ్లం ఏదో వచ్చింది చూడండి.
ఇది ఇక్కడ కరెంట్ పోయింది సార్, ఒక్క నిమిషం సార్ చూస్తున్నట్లే.
ఇప్పుడు బాగానే ఉంది మరి.
బాగానే ఉంది సార్, ఆడిబుల్ సార్.
యువర్ ఆడిబుల్.
Okay sir, thanks sir. Okay, sorry for the brief interruption. So if the PCO2 stays at 50 and pH is normal, it qualifies for a definition of chronic respiratory failure. So type 1 and type 2 obviously we have discussed. Something normal PCO2 with low oxygen is type 1. High CO2 with a low oxygen is type 2 respiratory failure. So one should be cautious about the impending respiratory failure. We should catch hold of the cases at this level, when the children with distress are having restlessness, anxiety, sleepiness, loss of consciousness, tachycardia, and all the profuse sweating, and all these things are the signs of impending respiratory failure. So the catchword is early intervention right at the stage of respiratory distress, rather than waiting till respiratory failure or shock sets in. So why children are more prone for respiratory failure? Obvious reasons. There's some anatomical reasons and physiological reasons. They are obligate nasal breathers. They have small airways. They have disproportionately bigger tongues. They have long, floppy epiglottis, pliable epiglottis. Larynx and trachea are highly placed than in adults, which contributes to the increase in the dead space and reduced functional residual capacity. The upper airway is conical in a child, whereas it is cylindrical in an adult. They have large tonsils and adenoids. Obviously, they have less number of alveoli at birth. The pores of Kohn and Lambert's canal, which connect the alveoli and equalize the air distribution in the alveoli, are less well developed in children than in adults. So here, the basically chest wall anatomy, they have horizontal ribs when compared to adults. Also, there is a very important physiological deficiency these children have is impaired outward recoil of the chest wall. They have good inward recoil as compared to adults, but they have a very lowered outward recoil. In essence, it means the expansion of the lung itself is impaired, so which contributes to the poor functional residual capacity. Also, the respiratory centers, apnea centers, and the RAS systems are less developed in a child. So this is a very important slide. I'd like to spend some time on this slide. Even a minimum edema of 1 mm in a child reduces the cross-section area with 75%, and also the resistance is increased 16-fold. Unlike in an adult, where it happens to the tune of 3 times resistance increase and 44% reduction in the cross-section area. So children are very, very, very highly prone for respiratory embarrassment and difficulties because of this phenomenon. And coupled with that, they have. Sir, am I audible, sir? Hello.
Yes, sir.
Yes, sir. Yes, sir.
Yeah. Coupled with that, children cry a lot with respiratory distress. So what it does is converts the normal laminar airflow into a turbulent airflow, which increases the resistance by 5-fold. That means the resistance increases 32-fold in a crying child. So the essence of initial management of a crying child with respiratory distress is to quieten the child. The best way to quieten the child is treat the initial, make the initial treatment in the lap of the mother. So very important. So it increases the resistance by 32 times. Radius to the power of 5. They have large occipits, and pharyngeal, oropharyngeal axis are aligned. So all these reasons make them more prone for respiratory distress as well as respiratory failure. So respiratory distress or failure usually happens in pathology in upper airway obstruction, lower airway obstruction, may have a lung tissue disorders and or disorders of the nervous system. So this is how it goes. Upper airway obstruction usually will have signs like stridor, barking cough, hoarseness, so on and so forth. Whereas lower airway obstruction will be more of a wheezing disorder with a prolonged respiratory phase. Grunting, crepitations, and decreased breath sounds will be more seen in the lung tissue disorders. And erratic breathing patterns, all these things will be seen more in case of a CNS problem, like your apneustic breathing, your chain strokes breathing, and so on and so forth. So any respiratory distress or respiratory failure will have to be assessed on the protocols what PALS provides us. Primary assessment would be ABCDE, which includes your airway, breathing, circulation, disability, and exposure, temperature. So if one doesn't take care at the phase of respiratory distress, obviously they will end up in respiratory failure. This is how it goes. This slide is from pediatric advanced life support, PALS protocol. So every effort should be made to treat respiratory distress aggressively, appropriately, before respiratory failure sets in. So how do you assist children with respiratory failure? With the usual pediatric assessment triangle, which has appearance, workup, breathing, color as its components. So assessment, as I have discussed, primary assessment will be ABCDE by the mnemonic: airway, breathing, circulation, disability, and exposure. Secondary assessment is usually remembered by the mnemonic sample. Sample is assessment of signs and symptoms, A is allergies, M is medications, past medical history, last meal, events leading to current illness. And tertiary assessment would include taking care of the etiological factors, which may be injury, trauma, infection. So it is a holistic management. If one goes systematically following the PALS protocol, obviously we would not miss out on the essence of management of respiratory distress. So how do you localize the respiratory distress by physical findings? So if it is upper airway, we have touched upon, it may be grunting, it may be stridor, it may be hoarseness voice, barking cough, so on and so forth. If it is a lower airway distress, it would be retractions, wheezing, grunt, crepitations, wheezing, also on pleural rupts and all those things. So by the physical findings, one may roughly localize the pathology to upper airway or lower airway. If it is a cardiac etiology, obviously it will be visible in the form of gallop rhythm or murmur or raised JVP, hepatomegaly, and so on and so forth. If it is a CNS, the very pattern of breathing will suggest the localization. Metabolic causes of respiratory difficulty is what we see in DKE, Kussmaul's breathing, or any asymptomatic conditions. So this is the characteristic sniffing position, what we see in acute epiglottis: anxious child, open mouth, alert, drooling saliva, and so on and so forth. So this is the tripod position a child adopts in respiratory distress so as to align the airway. This is the tripod position we all adopt when we really climb 5 or 6 stairs or we run fast. This is the posture we adopt. So which includes like leaning forward to make the airway in a straight line, Okay. So the retractions, if they are mild to moderate, they will be localized to the subcostal region, substernal region, intercostal region. As the severity increases, the retractions proceed cranially to supraclavicular, suprasternal, and sternal areas. So this till now we have discussed the types of respiratory failure, anatomical, the initial assessment and anatomical localization. Now we will dwell probably more time on the management. Sorry for rushing through the initial few slides. Sorry. So if you localize to upper airway, the cause for respiratory distress or respiratory failure, obviously if it can be group illness, you can use a Wesley score to score the degree of the grading of group, use nebulized epinephrine or corticosteroids. Dexamethasone is a drug of choice. If anaphylaxis is causing some upper airway obstruction, obviously your epinephrine and steroids are going to help you. If it's a foreign body, something like a Heimlich maneuver can be tried, or bronchoscopy, laryngoscopy removal can be done. If it is a lower airway obstruction, if it is something like a bronchiolitis, go for oxygen therapy and normal saline nebulization. Asthma, obvious by bronchodilators, and so localization will guide your initial management measures. If it is pneumonia causing distress, go for antibiotics and nebulizations. If it is a cardiogenic cause, obvious measures to tackle cardiac related events appropriately will be helping. If it is central cause, obvious majority of children will be requiring invasive sort of ventilation, because disorders of ventilation mostly result in type 2 respiratory failure. So how do you monitor these children? A very important entity is your alveolar arterial difference in oxygen saturation, oxygen. So normally the difference is very low, it should be less than 10. However, if the raising AADO2 speaks of a diffusion problem in the lungs. If it is more than 620, it straight away indicates the indication for ECMO. Arterial PO2 by alveolar ratio is also an index that is followed. But in day in and day out course, AADO2 is followed. This is the most very commonly followed index in our ICU, very easy to utilize, especially in ventilated cases. Any OI more than 40 carries a very, very high mortality index. So it can be used to monitor the response to treatment also. Anything more than 40 is indication for ECMO. So ventilation index is seldom used these days. PaO2 by FiO2 ratio is the index that is used to grade ERDS. Anything more than 400 is normal. Less than 200 is ERDS. Less than 300 qualifies for a definition of mild ERDS. So OI and PaO2 by FiO2 ratios are the most commonly used monitoring indices. OI slightly scores over PaO2 by FiO2, especially in cases who are ventilated with positive pressure. So now I'll spend a little more time on oxygen therapy, because this is where the crux of my today's talk lies in. Majority of cases are type 1 respiratory failures. Majority of times we fumble in providing appropriate oxygen therapy. Why? How? We'll discuss. Any child with a saturation of 92% do not give oxygen. So our first case scenario was showing a saturation of 97%. Child was having respiratory distress. Does it mean that child does not require oxygen? Yes, definitely. Oxygen with FiO2 not more than 21%. Normal 21% oxygen should be provided in a different manner. How we go about, we'll discuss. So any saturation less than 92%, give oxygen. Less than 70% in a child with cyanotic heart disease who have undergone surgery, give oxygen. If child has cyanotic heart disease, has a saturation of more than 60%, do not give oxygen. For newborns, it's a different entity altogether. Anything less than 91% is indication to give oxygen. So this is though it's adult data, I thought it would be very appropriate to discuss. A resting adult has a minute volume ventilation of 6 liters, because 12 would be the respiratory rate, 500 ml would be the tidal volume. Minute volume ventilation is 6 liters. However, if the same adult is doing exercise, something akin to respiratory distress in a child, the minute volume ventilation goes high as much as 90 liters per minute. So imagine a child who is breathing fast at the rate of 80 to 90 per minute. So coupled with that, there is an entity of hyperoxia induced associated lung injury or HALI. See, a high oxygen concentration given for a limited time carries high risk of oxygen toxicity to the lung. A low oxygen saturation, low oxygen concentration given for prolonged periods also carries a risk for lung injury. High oxygen for prolonged periods obviously has the highest risk for lung injury. So HALI is a very, very significant entity one needs to consider while providing oxygen. It's not like any child with respiratory distress, just put in a nasal prong or a face mask or NRB. It's not like that. So we'll discuss. So Joseph Priestley, who is credited with the discovery of oxygen, says candle burns in high oxygen concentration very fast. Likewise, high oxygen provided to an individual cuts down the life. They live out too fast and they may be exhausted in the pure kind of air. So high oxygen is dangerous. But the tragedy is children with respiratory distress, respiratory problems do need oxygen, and probably they need a more higher concentration for a longer time. So one has to balance out. In adult data, patients with COPD given FiO2 as low as 0.2 to 0.7 also had evidence of oxygen toxicity. Likewise, even short-term oxygen, the 18 to 48 hours short-term at supplemental oxygen as low as 2 liters per minute also amplifies production of reactive oxygen species which cause HALI. So a stretched lung at high oxygen versus a non-stretched lung and high oxygen. A non-stretched lung, high oxygen has slightly lower amount of surfactant levels, but see the drastic drop in the stretched lung and high oxygen group where it is very, very, very badly affected. The surfactant levels are badly affected. Likewise, if one studies the inflammatory markers, see the exorbitant increase in the tumor necrosing factor and interleukin levels in the stretched as and high oxygen levels. So, in essence, this is the hyperoxemia which results in VAP and denitrogen causes atelectasis, inhibits surfactant production causes atelectasis. There is activation of inflammatory cascade, associated HALI. All these 4 factors result in ventilator associated pneumonias and other issues. So hypoxia is dangerous, hyperoxia is also dangerous. So one needs to balance out. How we go about? Now we will just see what are the oxygen delivery systems routinely available. One is free flow oxygen, nasal prongs, nasal mask, your HFNC, CPAP, hood. These are all the different systems we have to deliver oxygen. So these are the low flow delivery systems. So they provide low flow, but they will result in high FiO2. So here, these are the high flow delivery systems, ventilators, CPAP, BiPAP. CPAP is more used in children. BiPAP is more used in adults. So your AirVo2, Vapoderms are all the equipment that are added to the present armamentarium in fighting this, treating these children with respiratory distress. So what are the problems with nasal prongs? Even at a flow rate of 6 liters per minute, we cannot exceed 6 liters per minute in a 2-year child, even with humidification. And also at 6 liters per minute, the FiO2 goes high as much as 44%. So same problem with the face mask also. We cannot give high flows. This is the formula for calculating FiO2 is 20 plus 4 into oxygen flow. Say for example, if the child receiving 6 liters, the FiO2 is 44%, which is how it goes. So even low flows will provide very high FiO2s by using low flow devices. The FiO2 goes as much as 95% when we are dealing with a oxygen delivery system like NRB, non-rebreathing mask. So flows and FiO2s do not match when we are using a low flow device. So this is a Venturi mask. Obviously flows are high, but your FiO2s are very, very high. So we'll revisit the first case scenario. Imagine a child of 10 kgs with a respiratory rate of 60 per minute and a saturation of 97%. So what is the flow required? 10 into 60. When the child is having respiratory distress, your tidal volume goes up. It goes high as much as 20 ml per minute. So 12 liters per minute would be the flow required. What is FiO2 required? Saturation is normal, 97. So we cannot go high on FiO2 beyond 21%. So any of the routinely used oxygen delivery systems, say consider nasal prawns, you cannot go beyond 6 liters per minute. Even at 6 liters, you are providing 44% of oxygen. Face mask has the same problem. NRBM may meet the flow, but it is providing 60% of FiO2. Venturi, high flow, and NRBM provides at 12 liters per minute provides almost 95% oxygen. Venturi at 12 liters per minute provides 60% oxygen. So we are failing on both the fronts, flow as well as FiO2. So that's the reason one needs to balance. The only way to balance both is by using your humidified high flow nasal cannula. This is how it looks like. See here, you can use heated humidified oxygen. You can regulate the flow. You can regulate the FiO2 also. So at 10 liters per minute, obviously you are going to use 95% in NRBM, but with the HFNCC, you can deliver 37%, you can deliver 21%, you can deliver 40%, whatever may the FiO2, you can definitely deliver it. So these are the interfaces available for HFNC. HFNC has remarkably reduced the number of ventilations, at least in our hospital. I can proudly say we have cut down the ventilation by 95% in our PICUs. Now, predominant modality of management is HFNC. So it is a case recently we have a couple of days back. Such a bad lung, presented with severe respiratory distress, had a pH of 7.16. This was at 11:02 p.m. in the night. See what happens after HFNC. At 12:23 a.m., see the pH has improved to 7.34. See the lactate has come down to 4.7 from 7. After the next day morning, look at the ABG. How pleasant is the ABG? Child is very comfortable. See how he's playing around. At presentation, child was extremely sick. So that is how HFNC works wonders. It reduces our workload, improves the outcomes, reduces the economic burden for the patient also. So at what initially we start with 2 liters per kg per minute, you can play with your flow rate as well as FiO2 appropriately. So it reduces the workout breathing as in any non-invasive ventilation. So initial when child settles down, you can reduce the flow as well as FiO2. FiO2 you can reduce it initially, then reduce the flow and wean off the child. So brief a few words about non-invasive ventilation. The non-invasive ventilation routinely we use is our CPAP, more in newborns than in pediatric population. It is delivery of the appropriate gases through an interface without the need for endotracheal intubation. So as discussed previously, it reduces the workout breathing, it maintains the patency. Even your HFNC creates a washout of the pharynx and transfers a positive pressure to the lower airways. So CPAP transfers it better, but your HFNC also provides some peak. And also it recruits alveoli, increases the FRC and decreases the ventilation perfusion mismatch. There are some contraindications, a very bad CNS lesion, cardiopulmonary arrest, GA bleeds, anatomical defects, and facial injuries are contraindications for non-invasive ventilation. So the case scenario 2, 3, 4 are obviously explained with the previous few slides. We'll go for the last scenario, which is type 2 respiratory failure. So obviously this child requires intubation and ventilation. Ventilation should be gentle. Then I would like to speak about lung protective strategies. FiO2, as far as possible, keep it below 0.4. You can achieve a low FiO2 by playing around with PEEP. So please do not use high PIP, as we have discussed. It stretches the lungs and causes obvious problems, which we have discussed. So PaO2 by FiO2 ratio can be accomplished by increasing your PEEP appropriately. This is a adult chart. In children, we usually don't go beyond 12 or 10. See, you can increase the PEEP from 5 to 16 with the increase the FiO2 from 0.3 to 0.5. This will recruit more lungs and help the patient prevent HALI, hyperoxia associated lung injury. So there is an entity called pervasive hypercapnia. Accept a higher PCO2s, 55, 60, even sometimes 65 also you can accept. It provides, by providing low volume ventilation, you can avoid volley trauma as well as the obvious pressure related barotrauma. Auto PEEP is avoided, barotrauma is prevented. In very tight situation, you can use low amounts of soda bicarb to minimize acidosis. Look here, increased CO2 has its own benefits. It shifts the oxygen delivery curve to the right side, so as the oxygen delivery is improved to the tissues. So there is an entity called pervasive hypoxia. So accept a saturations of 91 to 95. Less than 90 carries a higher mortality. More than 95 predisposes to lung injury. So accept a saturation of 91 to 95. Prevent hyperoxia beyond 120 to 140. So that almost concludes my topic. So this is one of the very interesting cases wherein for a child with respiratory failure, we failed to intubate. Even as it was probably 8 months child, the 2.5 size endotracheal tube was also not going. So what we did was we used a routine central cannula equipment, trocar and cannula. So we did a cricothyrotomy, passed in a endotracheal tube, and that child survived. The amount of satisfaction we got that day was enormous. So this is how we did. Emergency tracheostomy, ENT surgeon was not available, and there was no time also. So ultimately we did a tracheostomy. That child had a very large VSD, underlying VSD, had laryngeal stenosis, congenital laryngeal stenosis, got operated. The child is doing well on follow-up. So that is one of the very satisfactory moments in my 20 years of practice in Guntur. So take-home messages would be: classify the respiratory failure. Etiology should be obviously considered and managed. Oxygen is a drug. Use it judiciously. Hyperoxia, hypoxia, both are dangerous. Encourage use of non-invasive ventilation, especially HFNC. If the child requires ventilation, follow lung protective strategies, especially pervasive hypoxia and pervasive hypercapnia. So that concludes my topic. I thank IMA Tenali for giving me this wonderful opportunity. So I think I have been fast, but it's a huge, vast topic, as Narasimha sir said. I had to rush through. So thanks for the opportunity.
Thank you, sir. Thanks for your wonderful message and a highly knowledgeable topic.
Thank you, Prasad. If any questions are there, I would be eager to take up.
Chairperson proceeds.
Chandrasekhar, unmute Jayla, unmute Jay. Chandrasekhar, unmute.
Hello?
Unmute yourself, Chandrasekhar.
Hello?
Chandrasekhar?
Okay. So it is a nice and lucid lecture by T.C. Reddy. Congratulations. You concise it so nicely, such a vast topic. And I think many of the people who has seen this, heard this lecture, they should be able to know that the trend has been changing from the positive pressure ventilation towards non-invasive ventilation, because it was a fancy earlier to ventilate so frequently, which has resulted in a very drastic results because of the ventilated lung injuries. So now everybody is going towards the non-ventilation, which is rightly so. So the importance of the HHF NC was nicely discussed by Dr. T.C. Reddy. And this is the latest modality which has reduced a lot of ventilation nowadays. So all practicing pediatrician should remember that oxygen, as described nicely, is a drug. It is not a simple life-saving gas. So the drug has to be judiciously used. It should neither be used excessively nor underutilization. So, and another thing, the anatomical and physiological basis of a child airway is entirely different from the adult, and one should be able to realize these facts and proceed accordingly. Thank you, Dr. Sri.
Sir, thanks for the kind words, sir.
Hello.
నరసింహారావు
వినపడుతుందా?
వినపడుతుంది.
Thank you, Chandrasekhar, very much for the lucid presentation. And
Thank you, sir.
As I requested, you make it precise and simple. On present day,
the Chandrasekhar also summarized it very well at the present day necessity of non-invasive ventilation. Thank you very much for your presentation. Thank you.
Thank you, sir. Any questions? I would be eager to take up, sir.
okay.
If there are no more questions, we'll proceed further.
Okay, sir. Thank you, sir. Thanks for the opportunity. It was really nice to be a part of this CME. Thank you so much, sir, for the invite and the opportunity.
You are most welcome. My pleasure.
Thanks, one and all.
Great pleasure.
Let's move on to the next speaker. Dr. Shiva Prasad Babu.
Now I invite Dr. Lokeshwari Balete Garu for the next topic in pediatrics. She did MD Pediatrics from the Guntur Medical College in 2004 to 2007. Now she is working as a senior consultant at Sri Ramachandra Children's and Dental Hospital. Dr. Lokeshwar Garu also worked as a senior resident at Ramachandra Dental Hospital and worked as an assistant professor in Department of Pediatrics, Kattur Medical College. Presently involved in teaching at Sri Ramachandra Children's and Dental Hospital for DNB postgraduates, and also a executive body member for IAP, Indian Academy of Pediatrics Guntur branch, from January 29 to till date. Madam, to proceed in pediatrics. I invite Dr. Lokeshwar lecture.
Thank you, sir. Thanks for your kind introduction. And respected seniors and teachers. Hello, sir. Am I audible?
You have to share your screen, madam.
Yes, yes. Sir, is it okay?
Yes, madam. Go ahead, madam.
Okay. Thank you, sir, for your kind introduction. respected seniors and teachers, and my dear colleagues and friends. Good afternoon to everybody. My topic of interest today is approach to shock in children. This topic will go with definition, pathophysiology, staging, classification, clinical features, management through case scenarios, summary, and take-home message. Coming to the definition, shock is a dynamic and unstable pathophysiological state characterized by inadequate tissue perfusion, resulting in decreased tissue oxygen delivery. Shock develops as a result of decreased intravascular volume, that is preload, abnormal distribution of intravascular volume, that is afterload, and impaired cardiovascular function, contractility, and obstruction to the blood flow. Why is it important to recognize and treat the shock? Why? Because to prevent the invariable progression and poor outcome leading to end organ damage, finally end up with failure of multi-organ dysfunctions and death. So the unique physiological response to poor perfusion among children make it a challenge for the clinicians to recognize shock early and before hypotension develops, and response to the treatment is more favorable at this stage. Coming to the pathophysiological aspect, this inadequate tissue perfusion initially reversible, but when there is a prolonged oxygen deprivation, it will lead to generalized cellular hypoxia, derangement of the critical biochemical processes, and including cell membrane ion pump dysfunction, intracellular edema, leakage of intracellular contents into the extracellular space, and inadequate regulation of the parameters that determine adequate oxygen delivery to the tissues include the blood flow to the tissues by means of cardiac output, and the regional balance between the blood flow and the metabolic demand, and the oxygen content of the blood. These parameters are derived from these formulae. One is oxygen delivery, DO2, is a product of cardiac output and oxygen content of the blood, CaO2. Cardiac output again derived from heart rate and stroke volume. Stroke volume again dependent on preload, afterload, and cardiac contractility. Oxygen content of the blood is derived from hemoglobin into SaO2 into 1.34 plus 0.003 and PaO2. And finally, oxygen consumption is the product of oxygen delivery to the tissues as well as oxygen extraction. Coming to the stages of shock, it is of three types: compensated shock, hypotension shock, and irreversible shock. In the stage of compensated shock, the compensatory mechanisms will maintain the blood pressure. But if we are not intervening at this stage, it will end up with hypotension shock. And finally, if it is not corrected even at the hypotension shock, it will go into multiple organ system involvement, leading to irreversible shock. According to the etiological and pathophysiological aspects of the shock, the shock is classified into hypovolemic, distributive, cardiogenic, and obstructive shocks. Distributive shock is again included septic, anaphylactic, and neurological shock. But usually in pediatric patients, these shocks are not unique. They are usually multifactorial causative factors. What about warm and cold shock? It is due to maldistribution of the blood, increases systemic vascular resistance, and decreases blood flow to the skin, causing cool extremities and poor pulses, resulting in cold shock. Decreases systemic vascular resistance and increases blood flow to the skin, causing warm extremities and bonding pulses, will result in warm shock. The hemodynamic profiles in various types of shock include: in hypovolemic shock, the preload is decreased, cardiac output is decreased, systemic vascular resistance will be increased, capillary refill will be increased. Coming to the mixed venous oxygen saturation, it is low. In cardiogenic shock, preload is usually increased and cardiac output is decreased, systemic vascular resistance is increased, capillary refill time is also increased. Mixed venous oxygen saturation is low. In distributive shock, like septic shock, the preload is decreased, pump function will be increased, systemic vascular resistance will be decreased, capillary refill time will be decreased, mixed venous oxygen saturation will be high. In case of obstructive shock, the preload is increased, pump function will be decreased, afterload will be increased, capillary refill time is increased and mixed venous oxygen saturation is low. The common clinical features of shock includes tachycardia, skin changes, altered mental status, oliguria, lactic acidosis, and hypotension. The initial evaluation of shock may not be initially, cause of the shock may not be initially apparent, but we have to start the treatment immediately. And evaluation includes a systematic approach of history taking, physical examination, and initial investigations like blood glucose, electrolytes, urine evaluation, and if available, focused ultrasound examination. The goals of the initial evaluation of shock includes to identify the life-threatening conditions and treat emergently, like tension pneumothorax, hemothorax, cardiac tamponade, and pulmonary embolism, rapid recognition of circulatory compromise, and early classification of the type and cause of shock, so that our treatment will differ. The rapid assessment of shock is by means of pediatric assessment triangle, that is PAT triangle. Here we can assess appearance, work of breathing, and circulation of the patient. The recognition of shock includes ABCDE approach. A means airway, B means breathing, C means circulation, D means level of consciousness, and E means temperature. So in different types of shock, these all will differ. First, A means airway. We have to examine the airway whether it is maintainable or not maintainable. Coming to the breathing part, respiratory rate usually increased in case of all types of shock. Respiratory effort, whether it is increased, normal, or labored, we have to evaluate in various types of shock. Breath sounds usually normal in case of hypovolemic and distributive shocks, but crackles and grunting will be heard in case of cardiogenic and obstructive types of shock. Systolic blood pressure usually maintained in the initial period and then will land up with hypotensive shock in late stages. Pulse pressure usually narrow in case of hypovolemic and obstructive shocks, but variable in case of distributive shock. Peripheral quality of the pulse is weak, bounding, or anything else, we have to check it. Coming to the skin, whether it is pale, cool, or warm, cool, we have to examine. Capillary refilling time variable or delayed, we have to check. In case of hypovolemic shock, it is delayed. In distributive shock, it is variable. Urine output will be decreased in all types of shocks, and level of consciousness irritable and lethargic in late stages. The patient will end up with lethargy and unconscious state. Temperature will be variable according to the underlying physiology. A general approach to the classification of undifferentiated shock includes, after your history and physical examination, you will come to a conclusion that signs and symptoms of shock are present. So now, when included the history of trauma, you will examine whether it is a hemorrhagic shock or obstructive shock or pneumothorax or cardiogenic shock. If there is any history of fluid loss like vomiting, diarrhea, polyuria, hematemesis, and hematuria, then you will go for hypovolemic shock like gastroenteritis, DKA, third space losses, obstruction, like that. No history of trauma and no history of fluid loss, but presence of fever, hypothermia, and immunocompromised states will lead you to include in the septic shock. If all these things are normal, but there is a abnormal cardiac examination, then you will go through the limb of cardiogenic shock, like arrhythmias, myocarditis, congenital heart diseases, cardiomyopathy, like this. If no history of any abnormal cardiac exam, but patient is still having shock, history of any exposure to allergen, having wheezing and urticaria, will take you to the lead of anaphylactic shock. So these are the various classification of undifferentiated shocks and a flow chart to going into the specific details. Now we will go to the management part with regarding to the case scenarios. A 10-year-old girl rushed into the emergency department following several episodes of diarrhea and vomiting, and she is drowsy. Her heart rate is 152 per minute, respiratory rate is 28 per minute, SpO2 is 98%, BP is 88 by 44 millimeters of mercury, and peripheral pulses are feeble. Capillary refilling time is 5 seconds. So the physiological status of the child is hypotensive and hypovolemic. First, initial treatment should be started by 0 minutes by putting airway maintenance and also oxygen support. Within 5 minutes after oxygen support and airway maintenance, we have to secure the IV line. If not able to secure the IV line, we have to check the put an intraosseous line to treat the patient immediately. If it is a compensated shock, you can give the fluid of 20 ml per kg of isotonic saline within 5 to 15 minutes. If it is a hypotensive shock, you have to give that fluid same 20 ml per kg of bolus as a push and pull technique through a wide bore cannula. Okay, if IV line, if you are able to secure an IV line, you can put 2 IV lines. Okay, the type of fluid is isotonic saline, and speed of administration in case of compensated shock, it is 5 to 15 minutes. If it is a hypotensive shock, push and pull technique as speed as possible. And each and after every fluid bolus, we have to check for the therapeutic endpoints and the physiological goals like mental status of the child, quality of the central and peripheral pulses, skin perfusion, urine output, blood pressure. Blood pressure is, in case of less than 1 month, it is 60 millimeters of mercury should be the limitation, and 70 millimeters of mercury plus 2 into A's in years is the blood pressure, systolic blood pressure in case of 1 month to 10 years of age. And after 10 years, it should be more than 90 millimeters of mercury, upper limit of the normal values. Signs of fluid overload also you have to check with each and every bolus. If patient is stable after a single bolus, so it is fluid responding. So you can go for the maintenance fluids, as well as if able to take orally, you can straight away go for oral fluid therapy. And an evidence like in update of Indian pediatrics in 2020, the guidelines have changed. In resource limited settings, you should not give beyond 60 ml per kg of the bolus in the initial first hour of the resuscitation of a hypovolemic shock. It is only 40 ml per kg. Okay. Coming to the, if patient is responded to your initial 20 ml per kg, you can go to the maintenance fluid. If not responding, you can give 2 other boluses by within second bolus within the 30 minutes and third bolus within the first hour of resuscitation of the hypovolemic shock. If patient is not responding even after your 3 boluses and 1 hour 60 minutes after the starting of resuscitation, you have to search for the other causes of shock. So we will go to the second case scenario to look into the matter of 1 hour, even after 1 hour patient is not responding, then you will go for. A 2-year-old male child presented with history of cough, cold for 1 week, associated with fever for 3 days and breathing difficulty for 1 day. Heart rate is 180, respiratory rate 54, BP 60/40, pulses poor, capillary refilling time is 4 seconds, SpO2 92, respiratory system showing bilateral crepitations, retractions and mild grunt, and CVS is having S3 gallop and per abdomen soft hepatomegaly. So now we are dealing with a case of myocarditis. Here the fluid bolus should be 5 to 10 ml per kg only, that too within 15 to 30 minutes to cut short the overload on heart. The inotropic of choice here, it is dobutamine. Okay, and diuretics, there is no role in the setting initial stabilization, but diuretics are useful after stabilization to relieve the systemic and pulmonary congestion. Here in this case, there is a role of PEEP. Already sir, TC Reddy sir already discussed about the PEEP and PIP in case of respiratory failure. There is a role of PEEP in maintaining, decreasing the afterload, thereby improving the cardiac output in case of myocarditis. Excessive fluid resuscitation is very harmful in case of cardiogenic shock, severe anemia, severe malnutrition, SIADH, penetrating injuries, and obstructive shocks. So while giving the initial fluid bolus, you have to be very careful if the underlying causes or these cases, under these cases. The role of PEEP, on lung, it decreases the extravascular lung water and decreases the work of breathing. It works on preload by decreasing the venous return, increasing the pulmonary vascular resistance, and decreasing in the hypoxic vasoconstriction. It acts on the afterload by increases the intrathoracic pressure and increasing in the transmural pressure. It works on the heart by decreasing the oxygen demand and increasing in the oxygen delivery. This is the role of PEEP in maintaining the cardiac contractility. Okay. So the role of inotropes and vasoactives. After the first hour of fluid bolus, we have to go for the inotropes. If it is fluid responsive, we can go to the maintenance fluid and shift the patient to the ward. Even after your 3 boluses, if patient is not responding, you have to give vasoactives. They have a role in case of fluid and blood transfusion refractory shocks, and in case of myocarditis, and in case of septic shocks. So vasoactive medication we commonly use are norepinephrine, epinephrine, dopamine and dobutamine, and phosphodiesterase inhibitors like milrinone. Norepinephrine acts on alpha-1, beta-1 receptors and decreases the systemic vascular resistance as well as cardiac output. Epinephrine acts on alpha-1, beta-1 and beta-2 receptors and decreases the cardiac output, and at low dose it decreases the systemic vascular resistance, but at a higher dose it will increase the systemic vascular resistance. Dopamine at a dose of 0.5 to 2, it will act on the beta-1 and dopaminergic receptors and increases the cardiac output. At 5 to 10, it acts on alpha-1, beta-1 and dopaminergic receptors, and it will increase the cardiac output as well as systemic vascular resistance. At a rate of 10 to 20, it will act on alpha-1, beta-1 and dopaminergic receptors, increases the systemic vascular resistance. Okay, dobutamine, it acts on beta-1 and beta-2 receptors and increases the cardiac output and decreases the systemic vascular resistance. So these are the various drugs. At a dose of dopamine, we will use at a dose of 10 micrograms per kg per minute in cardiogenic and distributive shocks. Epinephrine, 0.05 to 1 microgram per kg per minute. In case of severe bradycardia with shock, pulseless electrical activity, post-cardiopulmonary arrest stabilization, hypotensive shock of all etiologies, and anaphylactic shock. Dobutamine, we will use at a rate of 5 to 20 micrograms per kg per minute in cardiogenic shock with high systemic vascular resistance. Norepinephrine at a rate of 0.05 to 1 microgram in case of low blood pressure with low systemic vascular resistance. Milrinone in case of cardiogenic shock with high SVR at a rate of 0.5 to 0.75 microgram per kg per minute. Okay, usually we will use epinephrine in case of cold shocks and norepinephrine in case of warm shocks. But if epinephrine and norepinephrine are not available, you can use dopamine at a low dose in case of warm shock and in a high dose at in case of warm shock. Okay. Coming to the case scenario 3, 36-hour full-term male neonate presented to the emergency department with difficulty in breathing, refusal of feeds, bluish discoloration of skin, and on examination, acral cyanosis, cool, clammy extremities, heart rate 188 per minute, respiratory rate 66, blood pressure 46 by 28, capillary refilling 5 seconds, cry activity NNR poor. So, common pathogens of shocks in newborn includes hypovolemic, distributive, cardiogenic, and obstructive shocks. Hypovolemic in case of hemorrhage and non-hemorrhagic conditions. Distributive shock is by sepsis and non-sepsis conditions like adrenal insufficiency, hydrops fetalis, and neonatal toxic shock syndromes. Cardiogenic in case of cardiomyopathies, arrhythmogenic tachyarrhythmias, and structural heart diseases. Obstructive shock in case of pulmonary vascular embolus and severe pulmonary hypertension, and mechanical like tension pneumothorax, pericardial tamponade, and constrictive pericarditis. These are the various modalities of shock in newborn presenting with shock. But here we have to take the consideration of cardiogenic shock. So if the patient is not responding to your initial fluid therapy in a case of newborn, you have to suspect duct-dependent cardiac lesion and start prostaglandin infusion even without an echo support. Even without an echo support, if you are suspecting any structural lesion. Okay, and you have to look for the all other causes of shock in case of the newborns. So if you are suspecting septic shock in the past present scenario, you can treat as like septic shock. If there is any evidence of acute blood loss, you have to provide RBC transfusion. If you are suspecting any adrenal insufficiency, you have to administer hydrocortisone. Other therapies you have to continue. But a newborn, here what I want to stress upon is, if a newborn presenting under 28 days presenting to you with shock, you have to suspect the ductus dependent congenital heart disease, and prompt administration of prostaglandin is warranted. The typical starting dose is 0.01 micrograms per kg per minute IV infusion. Okay. The case scenario 4, here 3-month-old female infant presented with history of fever of 3 days associated with poor feeding and decreased activity. Lethargic, heart rate is 180, respiratory rate 60, SpO2 is 94, capillary refilling is 4 seconds, blood pressure is 66/40 and pulse volume is low. Now we are dealing with a case of septic shock. So what are the red flag signs of septic shock? It includes fever of more than 100.4 degree Fahrenheit, hypothermia, tachycardia, tachypnea, abnormal pulse, abnormal capillary refilling, hypotension, and abnormal mental status. Purpura anywhere on the body or petechia below the nipple line are indicative of septic shock. Macular erythema and mucosal changes are also indicative of septic shock. Here we have to give 20 ml per kg of normal saline, and you have to give second and third bolus observing the patient's condition. Even after your second and third bolus, patient is not responding, then you can consider collide 5% albumin infusion in case of septic shock. Okay. Inotrope of choice is dobutam, initial dopamine, and then adrenaline for the cold shock and noradrenaline for the warm shock. Patients at risk of adrenal insufficiency considered hydrocortisone at a rate of 50 to 100 milligrams per meter square per day, or 2 to 4 milligrams per kg per day. So when the patient is not responding to your initial fluid bolus of 60 ml per kg at 60 minutes time, then you have to go for inotropes. If it is catecholamine resistant shock, then you have to give hydrocortisone. Okay. So role of steroids helps in improving blood pressure and catecholamine resistant shock, and also in case of adrenal crisis. Role of immunoglobulins, there is no significant evidence, but immunoglobulins have a clinical utility in case of myocarditis and myocarditis. Glucocorticoids, other immunosuppressive agents may be appropriate for in cases like myocarditis and autoimmune diseases. Okay. Coming to the blood component therapy in case of septic shock, packed cell transfusion should be advised if the hemoglobin level is less than 7 grams. If platelets are less than 10,000, you have to infuse platelet transfusions. If less than 20,000 with minor bleeding also, there is indication for platelets. If less than 50,000 with profuse bleeding, then you have to transfuse with platelets. FFP in case of deranged coagulation and bleeding tendencies. You have to start the antibiotic within 15 minutes of starting of resuscitation. This is investigation required in case of septic shock. All laboratory investigation, blood glucose, electrolytes, LFT, RFT, blood lactate, PT-INR, fibrinogen D-dimers, various cultures, inflammatory biomarkers like CRP, procalcitonin. These are the investigations required. After securing an IV line, you have to send the further investigations. Coming to the goal-directed therapy of septic shock, I have already discussed that within 0 minutes, you have to maintain the airway and also provide the supplemental oxygen. After that, within 5 minutes, secure an intravenous line if not possible, intraosseous line, and give the first bolus fluid, 20 ml of kg of Ringer's lactate. So repeat the bolus if required after 15 minutes and reassess after each bolus and give up to 60 ml per kg of balanced crystalloid fluid. If patient is not responding to the initial crystalloid fluid, then consider vasoactive therapy. And also check for any underlying cardiac dysfunction, any other causes for causing septic shock. Even after vasoactive therapy, patient is not responding, then consider hydrocortisone, 50 to 100 milligrams per meter square of hydrocortisone. Finally, even after your steroids, patient is not responding, there is a therapeutic usage of plasma exchange and plasmapheresis in case of septic shock with multi-organ failure. And there is a role of ECMO, extracorporeal membrane oxygenation, in case of septic shocks. The last case scenario, 8-year-old male presented with sudden onset of breathing difficulty and generalized pruritus. So child has irritable urticaria and flushing. So now we are dealing with a case of anaphylactic shock. Emergency management is by giving IM epinephrine at a rate of 0.01 milligram per kg intramuscularly. Okay, there is a role of albuterol if bronchospasm is there. Even after IM epinephrine, there is a role of H1 antihistamine and H2 antihistamine. H1 antihistamine diphenhydramine at 1 milligram per kg and H2 antihistamine famotidine 0.25 milligrams per kg. Glucocorticoids, considered giving methylprednisolone 1 milligram per kg IV after epinephrine and histamines. And after that, continuous non-invasive hemodynamic monitoring should be done. If there is any refractory symptoms even with these treatments, then you have to go for epinephrine infusion. Continuous infusion at a rate of 0.1 to 1 microgram per kg per minute. And all other therapies according to the protocol, initial fluid boluses, everything is normal for the same as like other scenarios. And coming to the final scenario, a 10-year-old female child presented with breathing difficulty for the past 1 week, and she has a heart rate of 132, respiratory rate 34, blood pressure 84/50, capillary refilling 4 seconds, SpO2 88%. So serious examination, there is muffled heart sounds and raised JVP. There is a soft hepatomegaly. So we are dealing with a obstructive shock. Here we have to give cautious fluid boluses, emergency management of cardiac tamponade, and pericardiocentesis and drain. These are the various case scenarios and managing modalities. I think I am through the shock management. Some of the pitfalls we are facing in day practices, that failure to recognize non-specific signs of compensated shock, like unexplained tachycardia, abdominal mental status, and poor skin perfusion, inadequate monitoring of the response to treatment, inappropriate volume for fluid resuscitation, failure to reconsider possible causes of the shock for children who are getting worse, and failure to recognize and treat obstructive shock due to pneumo, hemothorax, cardiac tamponade, and pulmonary embolism. These are some of the pitfalls. And coming to the summary, the management of shock in children requires rapid patient assessment. Okay. Children with signs of shock should receive supplemental oxygen to avoid hypoxemia. Vascular access must be quickly obtained as soon as circulatory compromise is identified. Children with shock receive isotonic crystalloids rather than colloids as an initial fluid therapy. Children with non-traumatic hypovolemic shock after 60 ml of, per kg of crystalloid should receive blood products, should receive colloid. In case of hemorrhagic shock, they should receive blood after 60 ml per kg of crystalloid solutions. Patients with obstructive shock require specific interventions, and vasoactive agents may be useful for children with shock who have not improved with the initial fluid resuscitation. Patients with arrhythmias and shock require treatment according to the PALS guidelines. Children with septic shock should be treated under the guidelines of 2020 Surviving Sepsis Campaign International. Children with anaphylaxis require prompt treatment with intramuscular epinephrine, diphenhydramine, and steroids. So nowadays there is a role of point of care ultrasound in early recognition of shock and management protocol, and as well as bedside echocardiography is also very useful in management of the management of the shock. So these are all with the help of these new things we will get through and treat the shock and to get the sick children back to the track. Okay. Thank you very much for the patient listening, and thank you very much for the IMA team for giving me this opportunity. Thank you so much, sir.
Thank you, madam. Thank you for your comprehensive and knowledgeable, informative topic in shock. Thank you, madam. Thank you very much.
Dr. Lokeshwari, you did am I audible?
Yes, sir.
You are audible.
Dr. Lokeshwari, you did a nice job. You have mentioned many a thing about the shock and such a vast topic. You have mentioned in a very nice manner and many a things to be remembered from your talk also. Just I would like to add a few things. And the shock itself is not an inevitable thing by both the patient and the doctor. Shock is such a cumbersome and difficult thing to treat once it has established. It is imperative to know, to recognize the shock in the early stages itself. So once if you recognize the shock in the early stage, it can be reverted very easily. So the most important subtle things one has to concentrate in their busy practice is a disproportionate heart rate and a disproportionate respiratory rate. These two things are very important. Why? The patient may be having fever, but is it proportional to the temperature? If it is not proportional to the temperature, both the heart rate and the respiratory rate, one has to think about some impending shock. Because hypotension is a very late thing, especially in the pediatric age group. Because the sympathetic tone is more compared to the adults in the children, so that the blood pressure will be maintained till the end. So once the hypotension is established, it is very difficult to come back. So recognition of the shock is a very, very important thing in the early stages. And few things I would like to mention is that latest guidelines for the shock treatment. So they have conducted a study in Africa regarding the boluses. Of course, it was mentioned by Dr. Lokeshwari, but one has to stress on it. Now the trend is going towards less boluses, less aliquots. Instead of 20 plus 20 plus 20, which comes to 60 ml per kg, is too much. So instead of allow the patient to drown and then treat him, so better not to allow him to get drowned. We do small aliquots. Now they are preferring 10 to 20, and now they are even going towards 10 even. So first you give 10 ml aliquots and see the response, and based on that you can repeat the dose. Instead of once the patient is locked with fluids, with lungs and all these things, it is very difficult to get rid of that fluid. So that is one thing. And the second thing is early institution of pressors are being recommended. And the role of the dopamine is slowly fading away. Fading away, it means that doesn't mean that you should not give it. You start with the dopamine. It is just like, as Suchitra Ranjit used to say, it is just like some GP handling the case. Dopamine is like that. So initially, you have to assess the condition and then send it to a specialist. The dopamine is something like that. So initially, you have to stabilize him, try to stabilize him with the dopamine, and as quickly as possible, go back to the pressors. Now the trend is more towards NARP. So in the low doses of NARP, it is very useful practically in all types of shocks. That is another thing. And another recommendation is, earlier we used to say cold shock and the warm shock. Now those terms has been almost removed, it seems, because there was a nice study conducted in India, clinical science versus the multimodal monitoring. So what they came to a conclusion, they have studied on some around 50 patients, they came to a conclusion that the clinical signs are not correlating with the actual the depth of the shock. So of course, it is not practicable in all settings, but nowadays the well-equipped ICUs are coming even at the district levels also. I think Dr. T.C. Reddy, it's not a problem to have to maintain a bedside echo and ultrasound and some X-ray vision. So all these three modalities, you can recognize and manage the type of shock and the intensity of the shock and the response to the treatment, so that you can de-escalate all the pressors or fluids or whatever it may be. So they correlate very well with the improvement of the shock patient rather than the clinical signs. So this is one good thing. The study was accepted internationally and the recommendation has been incorporated in the latest guidelines. So the important thing is give importance for the early subtle signs of impending shock and de-escalate him as early as possible. So thank you very much, Dr. Lokeshwari. You have elaborated so nicely, so concisely. You have confined to your time. And over to Dr. Narasimha Rao for his comments.
Narasimha Rao. Narasimha Rao, unmute yourself.
Hello.
You are audible.
Thank you, Lokeshwar Garu, for a beautiful presentation. And thank you, Chandrasekhar, for your update. And now we can go to for the next topic. Thank you all.
Thank you, sir.
Thank you, T.C. Reddy garu. Thank you, Dr. B. Lokeshwari garu, Dr. Chandrasekhar garu, and Dr. Narasimha Rao garu.
Thank you. Thank you very much.
Thank you. Thank you very much, sir.
Thank you all.
We'll go on to the next session, Shiv Prasad.
Okay, sir.
We'll go on to the next session. Hand over. Shiv Prasad, hand over the next session to the chairperson. Madam.
The next topic is ovulation induction in PCOS. Now I invite the speaker, Dr. Uma Shankar Garu. Dr. Uma Shankar Garu.
Good afternoon. Yes, sir. I'm audible, sir.
1 minute, sir.
Hello.
1 minute, sir. You're audible. Chairpersons will take over. Shiv Prasad Garu. Vanaja Gariki, Shivaranjani Gariki icheseyandi.
Okay, madam, please take over. The chairperson, I request the chairperson to take over.
Both the chairpersons.
Hello.
You are audible, madam.
Hello.
You go ahead.
Yes, this is Dr. Sivaranjani, Assistant Professor at GGH Guntur. Good morning, sir. Uma Shankar Garu. Am I audible, sir?
You are audible.
Yes.
Yes. Good morning, sir. Uma Shankar Garu. Welcome to your topic of ovulation induction in PCOS. Biodata will be shared by moderator, sir.
Who is having biodata?
Manuja madam, మీ దగ్గర బయోడేటా ఉందా మేడం?
Shall I read it out, sir?
Yes, sir. Yes, madam. Go ahead, madam.
Yes, Dr. Uma Shankar Garu. He was actually born at GGH Guntur itself in the year 1975. As you all pretty well know, he is the son of Senakaya Larana Garu and Gauri Shankar Krishna Rao Garu. He worked as a professor in Department of OBG at Koturi Medical College. And to his credit, he has many works and presentations. He also recently won an award at APCOG Karnool. He is an active member at International Fertility Society and also Indian Society. Coming to his education, he has his schooling at Sri Venkateshwara Balkutir and MBBS at JJM Medical College, Davangere. He has done his post-graduation at Bijapur University, Patil Medical College. He has done his diploma in minimal access surgery and IVF at Kiel University under Professor Mettler, Germany. He has also done 1 year of surgical oncology at NIMS under Raju Garu in 2002. And to his credit, he has also done service at PHC for 1 year. He has also worked at GGH Guntur for a period of 1 year. Welcome, sir. Welcome to this session.
Thank you for your kind words. I thank the team IMA Tenali, Samreddy Garu, Srikanth Garu, and our chairman Subramanian Garu for this to speak on PCOS, the generation of and complications. PCOS is a fast increasing disease of the modern era. The incidence was 9 and it is going up to 30% right now. The diagnostic criteria is 1990. There was a chronic anovulation, clinical and biological signs of biochemical signs of hyperandrogenism with
There is some
exclusion of
problem with the audio.
Uma Shankar Garu, there is a
Shankar
problem
Garu,
with audio
audio.
and video. You are not visible. Please check your
still no
gadgets.
Audio is not clear.
Just a minute, sir. 1 minute, sir. 1 minute. Maybe the net is a little bit slow, sir. Is it okay now, sir? Is it audible now?
It is clear now.
It's clear? Okay.
Okay.
Yeah, sir. So the incidence is around 9 to 30%. So initially it was 9 and now it is increasing up to 30% because of lifestyle modifications. So the diagnostic criteria for PCOS in 1990 was chronic anovulation, clinical and or biochemical signs of hyperandrogenism, and other etiologies are excluded. Both the criteria were needed in 1990. But due to difference in consensus, in Rotterdam, everyone has come to a consensus. We call it as Rotterdam criteria as 2003. That is oligo and or anovulation, clinical and or biochemical signs of hyperandrogenism, polycystic ovarian morphology. We need 2 of these 3 criteria to call it as PCOS. Again, there's a modification by the PCOS Society. This PCOS Society as clinical and or biochemical signs of hyperandrogenism, ovarian dysfunction, oligo-ovulation, and or polycystic ovarian morphology. Both these criteria are required to call it as a PCOS now. When you see a patient in when we see a patient in our OPDs, we have 4 phenotypes that we commonly see. One is androgen excess plus ovulation dysfunction, androgen excess plus polycystic ovarian morphology, ovarian dysfunction plus polycystic ovarian morphology. And we have all 3 combinations, that is androgen excess, ovarian dysfunction plus a polycystic ovarian morphology. Oligomenorrhea and hirsutism and obesity was common among the urban population. And interestingly, the urban population are diagnosed with having higher levels of insulin compared to rural population. There was a study that was conducted, and this is what is common. So what are the investigations that we require? That is, one is the transvaginal ultrasound. We need follicles of 19 to 25 follicles. We require blood investigations are DHEAS secreted by adrenal glands, androstenedione, total testosterone, free testosterone, hydroxyprogesterone, and SHBG. Other investigations that we require are serum prolactin, serum cortisol, serum FSH, LH, anti-Murrelin hormone, thyroid stimulating hormone, vitamin D levels. Because most of these patients, they have a metabolic abnormalities also. So we need to check GTT lipid profile. So let's come into the topic as such. What is the ovulation induction for normal ovulation induction and for IUI? So when you see and talk about ovulation induction, we divide the patients. Usually I divide the patient into 2 age groups. One is less than 35 and one is more than 35. Because it varies a lot when a patient on age. So we have oral medications, gonadotropin injections, we have a mixed, and we have laparoscopic ovarian drilling. So the oral medications are the most common and time tested is clomiphene citrate. So we start clomiphene citrate 50 milligrams and for 5 days. Either we start on 2nd day or 5th day, and it is continued for a maximum of 3 months. If you don't see any signs of ovulation, we increase the dose to 100 milligrams and then to 150 milligrams to a maximum of 200 milligrams. If you still don't see a success with 200 milligrams ovulation, we call it as CC resistant case and move on with the next protocol. So the success rate for ovulation with clomiphene citrate is 80%, and there's a chance of pregnancy around 20%. The problem with clomiphene citrate is they have high chance of multiple pregnancies. The next is letrozole. So letrozole is approved recently by DCGI. The dose of letrozole is 2.5 milligrams from day 3 or day 5 we can start. It is for 5 days. Remember, there are many literature that says we can use letrozole for 2.5, 5 and up to 7 milligrams. But in India, DCGI approved only 2.5 milligrams and we can use it for a maximum of 5 days. And we can use it for a maximum of 3 months. The success rate is the same, is almost the same on whichever day we start, whether 3rd day, 4th or 5th day. The success rate is around 30% with PCOS for live pregnancy. The ovulation rate is around 60% with letrozole, and the multiple pregnancy rate, as you see here, is far less, that is around 3% compared to clomiphene citrate, which is 7%. When you come to pregnancy loss with clomiphene citrate and letrozole, it is the same. So what are the adjuvant medications? PCOS, there's a lot of literature on adjuvant medications that come up. So we have metformin, dexamethasone, N-acetylcysteine, minoxidil, resveratrol, melatonin, and mineral supplementations. Let us start with metformin. Metformin is used in PCOS with hyperandrogenism and hyperinsulinemia. We start with 500 milligrams per day and 1 to 2 weeks. Slowly adjust the patient because metformin has side effects also. Some patients cannot tolerate it. So you acclimatize the patient slowly with 500 milligrams per day, increase it to a BD, and increase to a maximum dose of 1,500 to 1,500 milligrams per day. Dexamethasone, 2 milligrams from day 5 to 14 in clomiphene resistant cases. Dexamethasone is mainly useful to depress the androgens contributing from the adrenals. N-acetylcysteine is 1.2 grams per day. It can be used along with clomiphene citrate for 5 days. There is high chance of ovulation. The main reason why N-acetylcysteine is used is it decreases the testosterone levels. And most importantly, it can be used as a pre-treatment, that is 1 or 2 months before you start your ovulation induction. Minoxidil is also used for the same purpose, and it is used for the dose of 2 grams per day for BD for 2 to 3 months. Resveratrol is a grapeseed extract, and we need to use around 450 to 500 milligrams per day for 60 kg body weight. And it is also used pre-ovulation, that is 2 to 3 months before we start our ovulation induction. Melatonin. Melatonin is the most important hormone that is secreted for in everyone in the night. Due to lifestyle modification and due to increased usage of cell phones, the radiation and usage of phone more than the sleeping hours, that is after 11 o'clock, madam, that is after 11 o'clock in the night, delays the release of melatonin. Melatonin is usually released from 11 to 1 in the midnight. So if this melatonin is not released, it is important hormone that causes, hello?
Sir, you can carry on, sir.
Yeah, you're telling something, madam. So melatonin is
Melatonin.
Melatonin is an important hormone that is released and is responsible for cleansing the body in all organs. When it is not secreted, it increases the reactive oxidation species inside the body and thereby damage to the organs. And mineral supplementations are mostly vitamin D is required because there is deficiency of vitamin D in PCOS patients. So when you come to use of gonadotropins, so gonadotropins are used in 2 types, that is less than 35 and more than 35 age. So when you see a patient with less than 35, we start with a lower dose, that is 75 international units. We can use HMG highly purified or recombinant. The results are same. But there are some studies that says that recombinant HP, the isomer that is used in that doesn't give good oocyte quality, but it is up to the patient doctor's choice. So we have 75 units for age group less than 35 and 150 international units of a greater age. The age we are using in a higher age group, we are using more amount of gonadotropins because of age-related blunting of gonadotropin response. So once we start this as a 75 or 150, depending upon the age, we continue it for 3 to 6 days. On 6th day, we do an ultrasound. And when you do an ultrasound, you look at the follicle size. So here, if you see 10 mm follicles, around 3 to 4, you continue the same size. But if you don't see follicles or don't see adequate response, you increase the dose by half and continue again for 3 or 4 days and you continue. If you see a good response, continue the increased dosage till your follicle reaches 18 millimeters. And if you still don't see, you double the dose again up to a maximum of 20 days of a cycle. If you're planning to give HCG as a trigger, E2 levels to be monitored to prevent OHSS. If you see more than 6 to 8 follicles, that is a hyperstimulation, it is better to convert this IUI into a IVF cycle. And remember, if you see more than 6 follicles, you should be better to avoid HCG as a trigger and to give a GnRH agonist as a trigger. Step-down protocols are not used nowadays because whatever may be there is increased chance of poor oocyte quality or poor eggs that are developed in step-down protocols. GnRH antagonist is started when the leading follicle reaches 14 millimeters. Okay. In this cycle, and agonist trigger is given when the follicle reaches 18 to 20 mm. This is a very safe protocol with good pregnancy rates and with less OHSS chance. But there are some people who cannot afford a full gonadotropin cycle, so they would like to go for a mixed, that is oral tablets and HMG. So we can use letrozole and we can use clomiphene citrate. Just here, when you're using clomiphene citrate, we start with 100 to 150 milligrams per day for 5 days from day to day 5. HMG here, you start directly with 150 and use it for 6 to 10 days and using ultrasound monitor. And GnRH antagonist 0.25 milligrams per day is started when the leading follicle reaches 14 millimeters. So this is to prevent premature LH surge and to give a good trigger and to give a IUI timed according to the follicle size. So the results are 24% of these cases achieved clinical pregnancy. When we use letrozole, letrozole is used at a dose of 2.5 to 5 milligrams, but in India only 2.5 milligrams is allowed. But in many studies are there where we give 5 milligrams. It is used from day 2 to day 6 or 10 milligrams stat on day 2. Then HMG 150 to 225 depending upon age is started and the response is seen till day 7. And the trigger is usually given. So ovulation stimulation with letrozole followed by HMG improved pregnancy rates around 30% in this study. The agonist trigger is given when the follicle reaches 18 to 20 millimeters. So the trigger is always agonist to prevent OHSs. So there is laparoscopic ovarian drilling. This is a very old and time tested. It's very useful in some cases, but not used nowadays mainly because of gonadotropin availability. So how does it act? It decreases androgen levels by destroying ovarian stroma. So duration of effect is 6 months. So the advantages is a one-time procedure, no follow-up required, no monitoring, cheaper than gonadotropins. The disadvantages is laparoscopic complications and premature ovarian failure. The success rate for ovulation with laparoscopic ovarian drilling is around 40%. But now there is a trend that is coming up, but that has to be abandoned is many of the doctors, they start doing ovarian drilling when they put a case for diagnostic laparoscopy. So on a diagnostic laparoscopy, they see the ovary is looking big, the ovary is looking polycystic. Okay, let's do ovarian drilling. No, this should be avoided. If you want to do laparoscopic drilling, it should be a decision that is taken before the surgery, considering all the biochemical parameters, the ovulation pattern, the size of ovary. And remember, if you're doing laparoscopic drilling, the rule of 4 should be maintained. That is 4 seconds, 4 mm, and 4 punches per ovary. Once you do the puncture, you must cool the ovary with normal saline to prevent dermal damage to the adjoining oocytes. So what is the success rate when using these adjuvants alone? Is metformin when you use it is 7%, minoxidil is 15%, N-acetylcysteine is 35%, melatonin is 19%, clomiphene citrate is 18%, and letrozole is 60%. One of the most important things that helps in ovulation is weight management. I'll tell you about bariatric surgery, yoga, and exercise in a later slide. So what is the success rate for IUI with oral medication is 8 to 7%. Because nowadays, counseling, you have to give them success rate. That is where they make any decisions for them. So we have to tell them this is the success rate with this procedure, and based on that, they can take an informed decision. IUI with oral medications and gonadotropins is based on age. When it is less than 35, it is 12%, and with more than 35, it is 8%. IUI with total gonadotropin injection, antagonist and agonist trigger, 22 per cycle at less than 35 and 12 per cycle above 35 years of age. So when it comes to IVF, we have two protocols, the antagonist protocol and the agonist protocol. So the agonist protocol is no more used nowadays because there's a very high chance for OHSs. So that a standard protocol now for IVF in the PCOS patient is the antagonist protocol. So in antagonist protocol, you have fixed or flexible starting of antagonist. We need to give it agonist trigger. We'll be freezing most of the embryos, and ET is done in a different cycle. So agonist protocol is a long protocol, but very high chance of OHSs is not done mostly nowadays in PCOS. If you're doing an agonist protocol, you need to monitor the E2 levels, hematocrit, because there are chances for OHSs. So agonist protocol, the success rates is 10%, and generation antagonist protocol, it is 30%. In generation antagonist protocol, remember FET is done in the next cycle, and that success rate is around 50%. So this is the agonist protocol, but we are not using nowadays. So we use the antagonist, that is a fixed and a flexible start. On day 2 or day 3 of menses, we start gonadotropins. So the gonadotropins are started at the 150 to 225, depending upon age. And it continued till It's a fixed protocol. We continue till day 6 of using FSH. That is, after 6 injections, we start GnRH agonist. We are not bothered about the size of follicles, or it's called a fixed start. That is, day 2 we start, and after giving 6 injections, we start the antagonist. And from here, when the follicle reaches 18, remember the first follicle that reaches 18, we have to give a trigger, not when the last follicle that reaches 18. So when the first follicle reaches 18, we have to give a GnRH antagonist. We have to give a GnRH agonist trigger. HCG can be given, but there's high chances of OHSs. If you see a fewer follicles, then you can give HCG, but prefer to give GnRH agonist as a trigger when the first follicle reaches 18 millimeters. In a flexible start, again, we start our injections, gonadotropins. It can be HMG, it can be FSH, or it can be recombinant on day 2 or day 3 of menses. Again, continue. Here, instead of 6th day, we start when the GnRH antagonist on 14 millimeter size of follicle. When the first follicle reaches 14 millimeters, we start the GnRH agonist. The main reason for starting the GnRH agonist when the follicle reaches 14 millimeters is to prevent premature LH surge. And when the follicle reaches 18 millimeters, we give GnRH agonist trigger. So the incidence of OHS is 3 to 8%. The incidence of pulmonary edema is 0.2%. Ovarian torsion is one of the complications that we see in OHSs, and incidence is 0.2%. And bleeding for the ovary is 1%. And thromboembolism is very rare, but still a very dangerous complication. Still we see in 0.6% of patients who undergo stimulation. See, here I'll just touch upon the embryology aspects of PCOS, why it occurs and why the high number of antral follicles are there. Why they are there? Because of recruitment of more number of primordial follicles by IGF and androgen excess and increased VGF. We have poor quality of oocytes due to high androgen exposure. What everyone thinks is you have a lot of eggs, they'll be good. No, actually you'll get a poor quality of oocytes because of this high androgen exposure. So increased estrogen is there due to high androgen metabolites availability in the oocytes. Androgen enhance steroid production by granular cells. These androgens are produced mainly because there are a lot of granular cells, and these granular cells produce androgens that in turn damages the oocyte quality. What happens is excess androgens also decrease SHBG. So free androgens are more in follicular fluid, resulting into poor quality of oocytes. High testosterone levels leads to mitotically incompetent oocytes, and this leads to poor embryo quality. Hyperandrogenemia and hyperinsulinemia leads to more immature cells, GVs, that is germinal vesicles, on aspiration. So when you do a IVF, we see immature cells, GVs, because of hyperandrogenemia and hyperinsulinemia. And another thing is most of these patients are obese, and obesity leads to hyperinsulinemia, which stimulates ovary to produce excess androgens and gonadotropin resistance. In gonadotropin resistant cases, we use growth hormone inhibition is advised. So androgens decrease the production of glycogen in endometrium, which plays an important role in implantation. So one more important thing that we see is we get good embryos, we see good ET, but we are unable to produce a successful pregnancy because of excess androgens that leads to glycogen deficiency in endometrium that leads to implantation failure. So how to overcome all these things? So first, you avoid IVF in first stimulation. So all the bad eggs that are there, they all will go off. Try IUI with gonadotropins with minimum stimulation. 3 months of adjuvant medications, cycle regulation with OC pills, antagonist protocol, because this gives excellent results. What we do in our hospital is we use pure FSH for day 7 to 8 because technically HMG, there is a bit of HCG is there. And then we add HMG on 7th or 8th day till the follicle reaches 18 and we give a trigger. GCSF is added on day 7 or day 8. It improves the oocyte quality. Fertilization rate will tell us the embryo outcome. So 50% of eggs we use for IVF and 50% of for ICSI. The main reason we divide this is to know the exact quality of oocyte on the day of aspiration, so that if any changes are required, we can make it in the next stimulation protocol. We go for blastocyst transfer, and we freeze the embryos on day 3 so that we can allow the blastocyst for next cycle, and this will give a better results than doing a day 3 the next cycle. So when your patient is above 35 years, we advise them for bariatric surgery, a simple bulb. And when there's about 30, we advise them to go for yoga. And the best results are seen when the patient's BMI is less than 30. So what are the medications to prevent OHS after egg retrieval? In case if you're using a HCG as a trigger, cabergoline 0.5 milligrams for 8 days, enoxaparin for all the patients for 14 days because there is a chance of thromboembolism. GnRH agonist from day of oocyte retrieval for 5 days, IV albumin and high protein diet, and calcium chloride 10% in 100 ml, in 200 ml of saline, given in 30 minutes immediately after oocyte aspiration, and continued for day 1, 2, and 3 after aspiration. So what are the monitoring and investigations that you have to do after retrieval is treated as a major surgical procedure. You need to monitor pulse, BP, urine output, and respiration. Signs of ovarian torsion, that is severe pain that comes from a sitting posture, hydration, and you need to observe for 24 hours. And most of the things, the patient had an attitude that, okay, I've done an aspiration and I think I can go home. No, they have to stay back for 24 hours and they need to go only after 24 hours. And you need to call them on day 5, on day 7 to look for ascites and or late onset OHSs. Because this is early on OHSs and late onset OHSs are there. Because on day 7 or day 8, there is implantation and there is release of HCG, and then they can go for OHSs. We call it as late onset OHSs. So what are the investigations that you need to do before you discharge the patient on first day is hemogram, LFT, serum proteins, renal function test. And you need to do an ultrasound pelvis and abdomen on day 1 and day 5 to rule out ascites. Chest X-ray if ascites is present, and if you're planning to tap you need to do an ultrasound just before you do pleural tap. So what are the strategies to prevent OHS's complications? We call it as 3A, antagonist cycle, agonist trigger, and all freeze. So once you freeze the embryos, there is no chance of pregnancy and there is no HCG, and thus the patients are free of OHSs. But there are some instances where they can go to OHSs even if you start these procedures. That's why you have to be careful, and that's why you have to monitor them on day 1 and day 5 and day 7. So what is the latest evidence and research? Now the research is going on for genes that are responsible for PCOS. Improved diets are being devised for patients for PCOS, especially low carb diets, high protein diets, and less in oils. And the medications are alcoholics and OHSs, vasopressin antagonist, leclovaptan is being used to prevent OHSs. The take-home message is in syndromic patients, correct the metabolic syndrome first, and then you go for stimulation. If they are overweight or obese, put them to decrease the weight for less than 30 and then start your treatment. Ovulation induction can be with letrozole 2.5 milligrams is now standard, 5 days maximum, and it is for a maximum of 3 months. And gonadotropins, depending upon age, 75 to 150. Fixed GnRH antagonist protocol, that is day 6, you start your antagonist, agonist trigger, and you do OA 36 hours later. IVF fixed or flexible antagonist protocol is good. GnRH agonist is a trigger, and you freeze these embryos and transfer it in the next cycle. So depending on to know whether you want to transfer in the same cycle or in the next cycle, there's one more thing that we put. If there are less than 15 follicles, we can transfer this cycle. If there are more than 15 follicles, we freeze all the embryos and we do the next cycle. So prevent OHSs, you take all the steps that are required, even though you're given an antagonist trigger, agonist trigger, you have to take the steps that are required to prevent OHSs. Simple measure that we have seen in our clinic and works well is calcium chloride. And diet and exercise and lifestyle modifications to be stressed, and it holds the key for all the patients with PCOS in their future. Thank you.
Thank you, sir. Thank you, sir, for your engaging presentation. It was very informative, and you have covered every bit of the topic, and you have took the support of recent guidelines also, and you have even covered the difficulties even with IVF procedure in case of PCOS. And you have even covered the resistant cases and OHSs. Sir, shall I ask a few queries, as
Yes.
this is a very interesting topic for gynecologists,
Yes,
and
madam.
you are covering much about IVF because you are fascinated about it. And at this periphery level, we usually go for oral medication. Sir, coming to PCOS, uh, can you share us the experience and suggestion regarding the use of OCPs for cycles regulation before starting ovulation induction? What do you recommend?
We recommend 3 to 4 cycles of OC pills. Diane 35 is one of the best OC pills that we
Yes.
use. It's very useful. It decreases androgens as well as it controls the cycle.
Okay.
So 3 to 4 months before you start your stimulation, OC pill cycle regulation is always helpful.
What about the resistant PCOS with LH surge? Does it take care of it?
Resistant PCOS, yes, ma'am. See, once you start with OC pills and start down regulating them with the OC pills, all the hormone menu comes to normal, and they have a normal menu by the time of 3 to 6 months.
Okay, sir. And at the periphery level, we usually give HCG triggers. And is there any schedule or is there any recommendation for 5,000 units and 10,000 units,
For
depending on
when
follicles?
they give a trigger in PCOS, 6,500 appears to be good. The recombinant HCG that is coming up is really doing well, and 6,500 is what we use regularly in our clinic to for ovulation induction.
Sir, another thing of concern is utilized unruptured follicle. Most of the time.
Yes, ma'am. See, LUF is an entity that is no more if you're giving a good HCG. Because you're giving a HCG and you should be able to document its ovulation. If you're not giving HCG at a proper time, too early or too late, you will be seeing LUF.
So can we give a repeat trigger of HCG if you find unruptured follicle even after 40 hours to prevent the cyst formation in next cycle?
Already the changes that have to be taken are already occurred, and this HCG may not be helpful. The second HCG in this cycle, maybe to rupture the follicle, you can try it once.
For cyst rupture, we can.
You can try it.
So is there any practical tip you can share with us to get synchronous follicles?
Yeah, the practical tip is you start with OCs 2 or 3 months, and then you, at the same time, you metabolically, if she is having any abnormalities like hyperinsulinemia or diabetes or hyperandrogenemia, you use the required medications, and then you start your protocol. I think you'll have excellent results. And the most important thing, as I always say, which we are taking up very seriously nowadays, is lifestyle modification and exercise, where we keep a track of the patients, whether they're doing it or not. One of our staff is entitled to see every day that they follow up with yoga and exercise with us.
Yes. Another concern is almost all the gynecologists, they go for luteal phase support.
Yeah,
is it needed only for gonadotropin cycles or for all ovulation induction cycles you need it?
Luteal phase support is totally different.
Yes.
We usually recommend luteal phase support. We use dydrogesterone or micronized progesterone from 18th day.
For each and every case?
Every patient, irrespective of, because it is helpful in some of the cases, but we don't know which is not which is. So we universally we give it to all the patients. 10 milligrams or 200 milligrams vaginal progesterone. Dydrogesterone is 10 milligrams and vaginal progesterone is 200 milligrams per day vaginally. Or you can use a gel also for 10 days.
So it is mandatory to support luteal phase.
It's not mandatory, but it is advisory. But if you're using an agonist trigger, it is mandatory to support.
Mandatory. Okay, sir. And what about your experience with cabergoline, sir?
So
preventing OHSs.
Yeah, cabergoline works well. But the best I've seen is the most economical and the best is calcium chloride. When you give a calcium chloride, immediately after OHS, after pickup, and 3 days, it just goes off. Although we don't see any OHS at all. Cabergoline is not better than cabergoline. We see calcium chloride.
Okay, sir. Then regarding step-up protocol for letrozole, nowadays they are using almost 10 to 20 milligrams for extended periods also they're using 5 to 7.
Yes,
Do
ma'am.
you believe in that?
No, letrozole, because the regulations may have an effect because India has only permitted to use letrozole 2.5 milligrams for 5 days.
Okay.
So that will be off-label use. So it is not recommended. Maybe it is dangerous.
Sir, any words regarding poor responders, the management of the poor responders, and any tips you can give?
Actually, in gonadotropins, when we are giving also, we see some of the patients, they don't respond.
Yes.
So we call it as resistant cases.
Yes.
So in these resistant cases, we mixed with oral tablets and injections. We give subcutaneous GCSF, growth hormones. These are the adjuvants that actually help. And if you see a still resistant ovary, in these are the patients where the laparoscopic drilling actually helps. When they fail to oral medications, laparoscopic drilling followed by oral medications, they respond very well.
Yes. Maybe HPO axis also, we have to keep it in mind. Hypogonadotrophic hypogonadism also, we have to keep it.
That is a different. In PCOS also, you see poor response.
Yes. Okay,
in poor response in PCOS, especially, not in other cases. See, poor responders is totally different issue. In PCOS, where they are not at all stimulated to gonadotropins, you will be seeing some cases, or there will be delayed response mainly because of hyperandrogenemia. So you have to decrease the androgens in them. So that is the reason you need to do a ovarian drilling in such kind of patients, not in every patient.
Sir, at the periphery level, will you suggest any preventive measures for OHSS? You have already covered it.
So in periphery level, now GnRH agonist trigger is the best. So I think it is available everywhere. Instead of taking a risk with HCG, you can just give a GnRH agonist trigger and you support it with progesterone. So that should
and carefully monitor the patient.
Monitor the patient. So I told you day 1, day 5, and day 7. That's all.
Okay, sir. Thank you, sir.
Thank you.
Thank you so much.
Thank you all for giving me a chance to talk about PCOS today.
Thank you, sir. Very fantastic and excellent presentation, sir. You covered all the topic. Actually, I'm asking OHSS, but you completed, you covered all the things.
Thank you.
Thank you very much, sir.
Shall we move on to the next topic?
Next topic.
Can we introduce Dr. Rajakumari garu?
Madam Rajkumari garu, not online, madam.
Oh.
Yes. Yeah. 1 minute, madam. Yes, go ahead, Vanaja garu.
Good afternoon, ma'am.
Good afternoon.
I'm Dr. Vanaja, Amruta Nursing Home, Tenali. Welcome, ma'am. Dr. Rajakumari garu. She did MBBS in Sri Adi Chanchuri Medical College. She did MS in Sri B.M. Patil, Bijapur Medical College. She completed diploma in reproductive medicine, Kiel, German, FAMES. Fellowship in assisted reproductive medicine, Delhi. She worked as a professor in KMC. Now, she presently consultant in Ahalya IVF Center. Over to you, madam. Welcome.
Good afternoon, madam. I thank IMA Tenali for giving me this opportunity.
Ma'am, it is beeping, ma'am. Sound coming two times.
It is resounding.
Yeah.
You have to stop other gadgets surrounding you, madam.
My topic today is
Still resounding.
Sir, 1 minute, sir.
Madam, now how is it?
This sound is still there.
My topic today is preterm labor, risk factors and management. Is it audible now, madam?
Yes, Dr. Garu.
Yes,
So
yes.
you can go ahead, madam.
Yeah, thank you. Preterm labor is a adverse outcome to the mother and the obstetrician. When the primary gravida walks in our clinic and takes antenatal care, and we give advice regarding her visits. But suddenly, one day, she lands in our emergency setting with pains, uterine contractions, and cervical dilatation, and with imminent labor. We have come a long way now. We can identify women who are high risk for preterm, take proper steps to prevent it, and manage with tocolytics, and take care of the preterm with NH ventilators. Labor that occurs after 20 weeks gestation and before the completion of 37 weeks of gestation, regardless of birth weight, is preterm labor. My topic is preterm labor, and I will be covering the topics: risk for newborn and long-term consequences, risk factors and pathophysiology, signs and symptoms, initial assessment of preterm women, what is the treatment of preterm women, and what are the different tocolytics and how to choose the tocolytics. The adverse pregnancy outcomes which we see in a preterm baby are stillbirth, neonatal death, long-term physical and intellectual morbidities. The common complications in preterm infants include respiratory distress syndrome, intraventricular hemorrhage, bronchopulmonary dysplasia, patent ductus arteriosus, necrotizing enterocolitis, sepsis, apnea, retinopathy of prematurity. Lifetime consequences are chronic lung disease, grade 3 and 4 intraventricular hemorrhage, necrotizing enterocolitis, vision and hearing impairment. The follow-up of these infants show there is increased rates of cerebral palsy, neurosensory impairment, reduced cognition and motor performance, academic difficulties, and attention deficit disorder. The spontaneous preterm first manifests as cervical softening and ripening, decidual activation, and uterine contractions. Approximately half of the women deliver preterm have no obvious risk factors. The clinical risk factors are maternal factors, prior pregnancy history, and current pregnancy risk. The risk factors are divided into 4 pathogenic parts. One is the maternal and fetal stress, decidual amnion chorion inflammation, abruptio associated preterm, and mechanical stretching of uterus. All these 4 have unique biochemical triggers. The first, maternal and fetal stress. There is activation, premature activation of placental fetal hypothalamic pituitary adrenal axis, which releases corticotropin releasing hormone. The corticotropin releasing hormone increases cortisol, and this increases the placental corticotropin releasing hormone. And this increases prostaglandin F2 alpha and E2. These bind to the uterotonic receptors, mediate calcium flux, and trigger uterine contractions. And also prostaglandins, further they cause cervical changes and PPROM. After 28 to 30 weeks of gestation, stress associated activation will also enhance placental estrogen, as fetal adrenal gland is developed during this period of gestation and it releases DHEAL, and this increases the estrogen production. The second is the decidual amnion chorion inflammation. There is the systemic inflammation and genital tract infection. The systemic inflammation like periodontal disease, pneumonia, pancreatitis, pyelonephritis, and asymptomatic bacteria will cause preterm labor. The genital tract infections, which include bacterial vaginosis. There is outgrowth of the normal flora. Bacterial vaginosis causes preterm labor, and this reflects the role of innate immune response, which increases the expression of human necrosis factor, matrix metalloproteinases, interleukin-8, and cyclooxygenase pathways. In some women, also there is genetically determined exaggerated maternal and fetal inflammatory response. And in few infants, in some fetal, there is a different genotype, which also has a role in weakening the structural integrity of the membranes. So this may result in early rupture of membranes. So all this will result in preterm labor. Third is abruption-associated preterm labor. So bleeding in the decidia causes hemosiderin deposition. The vasculopathies may be associated with inherited and acquired thrombophilia. So one of the medical disease, hypertension and environmental stimuli, when they have abruptio, these may cause preterm labor because of the exaggerated matrix metalloproteinases. Mechanical stretching of uterus. Myometrial stretch increases expression of cyclooxygenase pathway, matrix metalloproteinases, and oxytocin receptor expression. So when there is increase in these, there is increased production of the prostaglandins. This will cause cervical ripening. So other risk factors are cervical procedures, congenital abnormalities of uterus, smoking, substance abuse, physical activity, nutritional factors, stress, poverty, education, less than 12, and lack of access to prenatal care, stress, and depression. All this will have one of the pathogenic pathways. We have under 4 heads: the maternal stress, inflammatory response, decidual hemorrhage, and multiple gestation. So these will cause increase in the corticotropin releasing hormone and increase of estrogens. There is increase of interleukin-1 tumor necrosis factor. So these will increase the cyclooxygenase pathway, prostaglandin dehydrogenase pathway, and decrease the progesterone. And also there is increase of the matrix metalloproteinases, interleukin 6 and 8 from fetal membranes and decidia and cervix. So these will cause cervical changes, EROM, and uterine contractions. So next is pregnancy history. Previous birth between 16 and 36 weeks, prior twin pregnancy, prior stillbirth, pregnancy termination, whether it is spontaneous or induced, will also result 1.5 to 2-fold increase in preterm labors. Current pregnancy risk, the mode of conception, especially IVF, super ovulations, all these also have, because of the stress, there will be increased rates of preterm labors. The bleeding in the present pregnancy, vanishing twin, multifetal gestation, uterine distension, polyhydramnias. So these also increase preterm labors. So when a woman presents with preterm labor, clinical care of mother in a preterm labor. So after once the woman comes, we need to know the cause, which is causing the preterm labor. So the cause, if we know, it may threaten the health of the mother and fetus. So what are the acute conditions? Pyelonephritis, pneumonia, asthma, peritonitis, trauma, hypertension. Obstetric conditions like preeclampsia, placental abruptio, placenta previa, chorioamnitis. In these patients, we need to deliver them. Fetal compromise may be acute or chronic. In acute, there will be abnormal fetal tracings. Chronic causes IUGR and oligohydramnios. Even in these patients, we have to allow them to have delivery. So question comes whether to start tocolytics or to allow delivery. So symptoms of preterm labor are pelvic pressure, increased vaginal discharge, backache, menstrual-like cramps, and uterine contractions which are more than 4 in 20 minutes or more than 8 in 1 hour. What are the other initial assessments? So we need to know the gestational age. Advanced labor, cervical effacement and dilatation will tell us whether she is in advanced labor. Confirmatory diagnosis by fibronectin. and amniocentesis for infection whether it is necessary. Anticipated neonatal mortality and morbidity. So if we know, we have to counsel the couple. Should labor be stopped? Transfer to NICU is required. Fetal lung maturity, tocolytes are required. And then send for laboratory investigation. So these are the initial assessment which we have to do when a woman comes in preterm labor. So laboratory investigations are hemogram to rule out anemia, blood sugar to rule out diabetes, WBC count, if it is more than 20,000 cells, we'll know there is any chorioamnitis or other infections. CRP is positive. Urine routine to rule out urinary tract infections, pyelonephritis, renal profile, and liver function test. These are important because we have to start them on tocolytics and vaginal swab cultures. So this will, with this, whether there are any infections in the vagina. Signs and symptoms of preterm labor. With signs and symptoms, we can diagnose she is in labor. Examination, how is the pulse, whether there is any tachycardia, temperature, fever is present or not, what is the fetal heart sound, and CTG. Sterile speculum examination, to rule out PROM, you have to see whether there is any pooled fluid. Fibronectin swab from posterior fornix, cultures from cervix and outer third of vagina to rule out group B streptococcus. Abdominal ultrasound, placental location, fetal well-being, and AFI. Cervical examination. If it is more than 3 centimeters and more than 80% effaced, preterm labor is confirmed, and we have to decide whether tocolysis will help. Cervical dilatation is between 2 to 3 meters and it is less than 80% effacement, and uterine contractions are present. Then we need to a cervical ultrasound, and we have to decide whether to give tocolysis. When cervix is less than 2 centimeters dilatation and less than 80% effaced, then preterm labor is uncertain. Use of cervical length, if it is less than 20 mm and there are contractions, then we can diagnose it is preterm labor. Cervical length is 20 to 30 mm and there are contractions, then it is probable preterm. Cervical length is more than 30 mm. So cervical length is good. So preterm labor is unlikely. So treatment of preterm labor, when we are treating, we have to do these 4 things. One is maternal transfer, antibiotics for group B streptococcus, antenatal administration of corticosteroids to reduce neonatal morbidity and mortality, and administration of maternal magnesium sulfate to reduce incidence of cerebral palsy. So maternal transfer is when we have a good NICU, then we can deliver the preterm woman and put the baby in NICU. But when we don't have a very good NICU, then it is better to transfer the mother. Antibiotic treatment in preterm labor. This is to prevent streptococcus, and it is not effective in preventing pregnancy or preventing preterm labor. It can be reserved in group B streptococcus prophylaxis, women with PROM, and treatment of a specific infection like UTI. And corticosteroid. This is to promote surfactant synthesis, increase lung compliance, increase maturational effect. And also corticosteroids, they have maturation effect on brain, kidneys, and gut. Dose is betamethasone 12 milligrams, 2 dose 20 hours apart. Dexamethasone 6 milligrams. The benefit starts after 48 hours of first dose and lasts for 7 days. Single steroids were given more than 2 weeks prior. Even if labor is imminent, steroid single dose is given. Reducing risk of cerebral palsy. 4 grams of bolus of magnesium sulfate for 30 minutes with 1 gram per hour maintenance dose. It is appropriate for women with PPROM or preterm labor. It should not be delayed. It can be given between 24 to 30 weeks of gestation. And when we give magnesium sulfate infusion, deep tendon reflexes, input-output chart, and respiratory rate should be maintained because we want to prevent magnesium toxicity. Tocolysis. Types of tocolytics are beta-2 receptor agonist, ritodrin, terbutaline, calcium channel blockers, nifedipine, magnesium sulfate, oxytocin receptor antagonist are etosiban, and cycloogenase inhibitors are indomethacin. Recent Cochrane meta-analysis of tocolytic agent indicate that calcium blockers and oxytocin antagonists can delay delivery for 2 to 7 days. Beta-mimetic drugs delay delivery for 48 hours but carry greater side effects. Cycloogenase inhibitors, there are insufficient evidence, and magnesium sulfate is ineffective as a tocolytic. The principles of using a tocolytic therapy. So tocolysis can be started between 24 to 33 weeks, 6 days gestation, and along with tocolytics, steroids also should be started. Tocolytics are used for 48 hours. They do not improve perinatal mortality. Insufficient evidence to start multiple tocolytics as a primary tocolytic. So primary tocolytic is when the woman lands in preterm labor, you can only start one tocolytic and should not be started with multiple tocolysis. And refractory tocolytics, when one tocolytic is not working, we cannot start with change the tocolytic. There is insufficient evidence. Also, tocolytic. Contraindications for tocolysis are maternal chorioamnitis, severe vaginal bleeding, abrupt show, preeclampsia. And fetal contraindications for tocolytic are intrauterine fetal death, fetal anomaly, and fetal maturity. After 34 weeks, then tocolytics have no role. The first calcium channel blocker, mechanism of action is it blocks the entry of calcium inside the cell. That is, it acts at the calcium channel. The dose is orally 10 to 20 milligrams every 3 to 6 hours. Side effects are maternal hypotension, headache, flushing, and nausea. It should not be combined with beta emetics or magnesium sulfate. This should be avoided when we start nifedipine. Magnesium sulfate, it acts like competitive inhibition of calcium ion, decreases cell choline release. The loading dose 4 to 6 grams IV, 10 to 20% solution over 22 hours, followed by infusion of 1 to 2 grams per hour. To continue tocolytics for 12 hours after contraction has stopped. It is relatively safe. Common side effects are flushing, perspiration, headache, muscle weakness, and rarely pulmonary edema. Neonatal side effects are lethargy, hypotonia, and rarely respiratory depression. One thing we have to be careful when we are starting magnesium sulfate is it is complicated. Cycloogenase inhibitor is indomethacin. It decreases the synthesis of prostaglandin and thereby decreases intracellular free calcium accumulation. The dose is 50 milligrams per oral or per rectal. It also can be given vaginal or rectal, followed by 25 milligrams every 6 hours for 48 hours. Side effects are heartburn, GI bleeding, thrombocytopenia, and renal injury. Contraindications, hepatic disease, active peptic ulcer, coagulation disorders. Fetal and neonatal side effects are constriction of ductus arteriosus, hypohidrosis, neonatal pulmonary hypertension. Indomethacin should not be used for more than 48 hours and it should not be given after 32 weeks as it is associated with fetal risk. Beta-mimetics, mechanism of action is activation of intracellular enzymes. It decreases the intracellular free calcium, thereby smooth relaxation. Ritodrin is given IV infusion 50 micrograms per minute and is increased by 50 micrograms every 10 minutes. Side effects are headache, palpitation, tachycardia. It should not be given in diabetes because it may cause hyperglycemia, pulmonary edema, and hypertension. Fetal side effects are tachycardia, heart failure. And neonatal side effects are hyperglycemia, intraventricular hemorrhage. Oxytocin antagonist is etosiban. Mechanism of action is it blocks myometrial oxytocin receptor. It inhibits intracellular calcium release and thereby inhibits neonatal contraction. It is a bolus dose first, 6.75 milligrams, then 300 micrograms per minute IV for 3 hours, and then followed by 100 micrograms per minute, maximum 48 hours. So 100 micrograms per minute, one drip should come for 9 hours. Maximum 5 doses have to be used. Nitric oxide donor, example is glycerol nitrate, causes smooth muscle relaxant. It is available as patch. So next, mode of delivery. We have this dilemma whether to deliver by vaginal or do a cesarean delivery. So in abnormal fetal tracings, preeclampsia, breech or malpresentations, abnormal vaginal bleeding, oligohydramnias, or when there is a prolonged labor, then we can do a cesarean section. But we have to keep in mind that in these babies, we have to do a delayed cord clamping, about 60 to 120 seconds. We cord clamp after 30 seconds. So in them, we have to delay cord clamping. So take home message, cause preterm to be identified first. The fetal be assessed. Contraindications of topologies should be ruled out. Antibiotics is given to prevent group streptococcus. Antenatal corticosteroids to be given along with antibiotics. Magnesium sulfate is given for prevention of cervical for 48 hours. Ultrasound measurement of cervical length should be done between 24 to 28 weeks, and fetal fibronectin can be measured. And I thank you. I thank the IMA staff for giving this opportunity in participating in the CME.
Ma'am, please unmute.
Thank you, ma'am. Very
Thank
nice
you.
presentation and covered all the things.
Thank you.
What about
Thank you, madam.
progesterone treatment, ma'am? Progesterone supplementation?
Yes. Madam, in women who are risk of preterm labor, like if they had already a preterm labor in the first pregnancy or in the previous pregnancy, then in the next pregnancy, we start progesterones. That is from 16 to 20 weeks and continue till 34 weeks. Or at least till they deliver, we can continue progesterone. Progesterones can be vaginal progesterone or hydroxyprogesterone also.
Oh. Dydrogesterone?
One of the progesterone, madam, dydrogesterone, vaginal progesterone, or 17-hydroxyprogesterone.
Okay, okay, ma'am. Okay, ma'am. Okay. Antibiotic is preferable, ma'am?
Madam, antibiotics are given to prevent group B streptococcus. It is ampicillin, sulbactam, or cefazolin. This is the antibiotic which we give. But if there are any systemic infections, other infections, depending on the systemic infection, we have to choose the antibiotic. And they are given for 5 days.
Okay, okay. Okay, thank you, ma'am.
Thank you, madam.
Ma'am, excuse me. Madam?
Madam,
Madam, in case of twins, we have every chance of the patient going into preterm labor. Is there any role of prophylactic stitch in those patients? Twin pregnancy, which is precious.
Madam, twin pregnancy is a risk factor because there will be a mechanical stretching and there will be cervical dilatation. There are two different dilemmas, madam. One is you can put a cervical stitch, but still because of the mechanical stitching, they can have a preterm labor. So another study says there is no role of putting a cervical stitch in them.
Okay, ma'am. And we routinely put
In
progesterone
our
supports.
setup,
Not this. This is
progesterone,
another. I'm talking about tocolysis.
we have
prophylactic.
to, yeah.
Another
We have
another
to
query
start.
is. Another
Yes,
query
ma'am.
is, if we are starting tocolysis, till how many weeks do you recommend to continue? Because it will be associated with maternal complications also. Cardiovascular problems for the antenatal women can also appear. Is it till 34, 36 or till 37 completed weeks? Tocolysis.
Madam, you prophylactic tocolysis, madam?
Yes. The patient is having previous history of preterm labor.
And these are given only when there is an active preterm, and we can continue at least for 1 week.
Okay. Till the mother is shifted to a safe place.
Yes, ma'am.
Okay, ma'am. Thank you.
Thank
Thank you, ma'am. That was an excellent presentation.
Thank you, madam. Thank you.
Sir, can I play national anthem?
I thank the IMA members, IMA Tenali, for giving me this opportunity in participating in CME today. Thank you.
Thank you, madam.
Thank you.
Sir, can I play national anthem?
No. Wait a bit. Dr. Srikanth?
I request Dr. Bhimaram Samiruddy Garu to give the closing remarks.
It seems Dr. AVP, is he there?
Samiruddy Garu, Lingareddy Garu kuda vastunaru.
రమ్మనండి. డాక్టర్ ఏవిపి కూడా ఉన్నారేమో చూడమనండి ఒకసారి.
ఏవిపి గారు
నేను చెప్పాను వస్తా అన్నారు.
The number you have dialed is currently busy.
ఏవిపి ఏంటి? ఓ అవునా, సరే 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 అయితే క్లోజ్ చేసేస్తున్నాం అయితే. ఓకే ఓకే. Dr. AVP is in the Zoom, but he is not able to connect because of some technical problems. Okay, dear friends, it is a very enthusiastic and very, very enriching session, all the sessions, and I thank all the members who have participated, all the chairpersons and moderators who have done an excellent job, and all the speakers also who could give us very useful and informative speeches. And again, I take this opportunity to thank all the people who have helped us in making this event a grand success. Thank you all. I request Srikanth to speak.
Yes, sir. Good evening, everybody. Before we go on to vote of thanks, I'll just give the statistics what happened in the last 2 days. Actually, we have to close the registrations because the limit which was given by AP Medical Council is 500. So more than 500 delegates can't participate in a conference in this online CME. So actually we started registrations 1 week ago, and till yesterday morning before the event started, our registrations touched precisely it is 457. It almost reached 500. So we have to close it by before we start the CME. Even after starting the CME, also we had many calls allowing people asking us, asking them to be allowed into the conference in the CME. We could not do that because we have a limitation, and we can't start before the CME. We have to send the list to the AP Medical Council. So we closed yesterday morning at around 2 o'clock. We closed the registrations, and we have to send the list to the AP Medical Council. And we had 16 speakers who participated in yesterday's and today's program, and we have 16 chairpersons also and 4 moderators who guided us through this 2-day session. I think this is the first time the IMA Tenali is conducting a 2-day CME, which extended over, if I remember right, I don't know.
About the past. It's right. You are right.
Before Saturday and Sunday. I would like Dr. Akhilesh to give the vote of thanks.
No. But I would like to invite Dr. Lingareddy to speak out a few words.
Sir, you are not online, sir. Lingareddy garu.
He unmuted, but he is in.
Yeah, I think I told him to come.
You are having his phone number?
Yes, sir. Calling him. వినపట్లేదు సార్, మీరు అన్మ్యూట్ చేసి మాట్లాడండి సార్. ఒక్క నిమిషం సార్, మళ్ళీ అన్మ్యూట్ ఒక్కసారి నొక్కండి సార్. వినపడలేదు అందుకని.
అన్మ్యూట్ చేసింది కానీ రాలేదు. ఆడియో ఎందుకని రావట్లేదు?
ఆడియో సమ్ ప్రాబ్లమ్ విత్ ఆడియో సార్. లింగారెడ్డి గారు, మీరు ఇయర్ ఫోన్స్ అంటే ఉంటే తీసేసి మాట్లాడండి సార్, డైరెక్ట్ గా మాట్లాడండి.
Yeah, you are not audible, Lingareddy garu. No. You are not audible.
Sir, you are not audible.
Sir, once again join, sir.
Now you are audible. Again gone. No, you are not audible.
లింగారెడ్డి గారు ఒకసారి మళ్ళీ లాగిన్ అవ్వండి సార్.
లాగిన్ అవ్వండి.
మళ్ళీ లాగిన్ అవ్వండి సార్.
Sir, am I audible to you, sir?
No.
Yes, go ahead, sir.
Clear. Clear.
Good evening, everybody. At the outset, I would like to thank IMA Tenali for giving me the opportunity to witness the beautiful proceedings from yesterday onwards. My special thanks to Dr. Samiredi Garu and Srikanth Garu. Thank you very much, sir. Over to Srikanth, sir.
Akhilesh, vote of thanks. Thank you, sir. Lingareddy garu.
Thank you, sir. Thank you.
Good evening, all. Good evening, all the members. Sorry, am I audible, sir?
Yes, go ahead. Akhilesh, Cheppisi.
Sir. Good evening to all the members. On behalf of Tenali IMA executive members, I thank State IMA President and Secretaries, Andhra Pradesh Medical Council Observer Dr. Lingareddy Garu, to all the speakers, chairpersons, and observers, and the technical team supported by Expocon and all the technical staff and IMA Tenali staff, and to the respected members of Tenali IMA. Thanking you also.
Thank all the people who have registered. Akhilesh.
Bashir, play the national anthem.
Okay, sir. Okay.
Thank you, sir. Machilipatnam, చాలా బాగా కండక్ట్ చేశారు సార్.
Thank you, sir.
Thank you, sir.
Thank you all the members who attended the conference, sir.
Samiredi Garu, thank you.
Thank you.
Dr. Srinivasachari, thank you, sir.
Thank you, sir.